The subcommittee hearing will come to order. Today, the subcommittee is meeting for the third hearing in the Making Healthcare Work for American Families series. In the previous hearings, we heard from the leading experts in healthcare that our delivery system is dangerously disconnected and that providing universal coverage means affordable and quality health plans for all. Today, we'll explore the next step. Simply providing universal coverage will not guarantee that everyone will have access to the necessary care. We must also eliminate the inequities and disparities in healthcare, properly support and train our healthcare workforce, and make prevention a national priority. As a nation, we've made tremendous strides in improving the health of all Americans. However, as numerous reports have highlighted, there remain significant inequalities with respect to both access to health care and the quality of care provided among different ethnic groups in this country. For example, the mortality rate due to heart disease and cancer is higher among populations, including African Americans, Asian Americans, and Pacific Islanders. The rate of new AIDS cases is 3 times higher among Hispanics than among Caucasians. I personally am also very concerned about the health disparities for American Indians and Alaska Natives. The mortality rate among Indian infants is 150% higher than for Caucasian infants, and Indians are nearly 3 times as likely to be diagnosed with diabetes. These disparities are not limited, however, to ethnic and racial divides, but are consistently also found between genders, geographic area, and among different income groups. For example, there are significantly more access to care obstacles for rural populations than there are for urban populations. And the 2002 Institute of Medicine report found that these disparities persisted even when factors such as insurance coverage and income level remained constant. And one of the contributing problems in my mind is the current state of the healthcare workforce. Study after study has proven the importance of primary care. Yet 2/3 of the U.S. physician workforce practice as specialists, and the number of young physicians entering primary care fields is declining. In addition to this, there are disparities in where these physicians are practicing. Metropolitan areas have 2 to 5 times as many physicians as rural areas, and there is a shortage of physicians willing to practice in economically disadvantaged areas, both rural and urban. Part of the solution, in my mind, is to strengthen our existing programs while at the same time exploring new avenues to reduce disparities and expand the workforce. As highlighted in a recent Commonwealth Fund report, Medicaid is vital in improving access to health care for low-income Americans. Title VII and VIII of the Public Health Service Act are crucial programs to increase the primary care workforce, and the National Health Service Corps is a very successful program to entice young medical professionals to practice in underserved neighborhoods. Though we face many obstacles in ensuring access for all Americans, I'm optimistic that in this Congress we will take action to ensure that all Americans have both coverage and access to care. I want to welcome all of the witnesses today. I do want to say that certain members, not to take away from the others, but Ms. Christensen, was very crucial in asking that we have this hearing today and address some of the disparities issues, and certainly Ms. Capps, who is our vice chair, constantly making reference to the workforce and the need to address those workforce issues. And with that, I'll ask Mr. Deal to begin with an opening statement. Thank you.
Thank you, Mr. Chairman. I want to also express appreciation to all the witnesses for being here today. As we move forward in this series of hearings looking at what health care reform should encompass, I think there are some fundamentals that we all ought to keep in mind. I believe that some of the true issues in health care reform include transparency, efficiency, and accountability in the health delivery system, and allowing a system to exist that involves the patient's right to choose. This hearing, of course, is going to focus on access to health care services and various proposals aimed to overcome the obstacles to care. Unfortunately, too many Americans across the country do lack access to quality, affordable medical care. As we all know, there are a variety of reasons why this exists. Physical, geographical, cultural, and financial influences all play a role in patient access to health care. While there are scores of obstacles to stand in the way of receiving it, effective reform such as cross-state purchasing of health insurance, association health plans, consumer-driven options that enhance quality and value, and similar options which build upon the doctor-patient relationship would make great strides forward in bridging the gap that exists under today's system. There's a lot of talk in Washington that suggests that the most appropriate way to put our health care delivery system back on its course is to increase the role of government-run health care programs, particularly Medicare, Medicaid, and SCHIP. I, of course, don't agree with that proposition. Patients receiving care through Medicaid oftentimes find it very difficult to find a physician who will accept their coverage, due at least in part to abysmal reimbursement levels rendered for their services. Medicaid participants are frequently forced to travel great distances to receive access to needed care. In fact, just before the hearing today, I had an opportunity to meet with a group of podiatric physicians from my district, and they reiterated the challenges that their Medicaid patients face in finding a provider who will actually accept their coverage. In my rural district in North Georgia, this presents a significant challenge to many of my constituents, and funneling even more individuals into government-run health care programs without addressing the heart of these programs does not reflect the reform that the American people are asking for. Additionally, Congress should also consider other reforms in the health care delivery system. I believe that any package we send to the floor should include a significant medical liability reform provision. Time and again, we hear repeated instances of frivolous lawsuits for medical liability cases being brought against health care providers as trial lawyers seek to exploit every opportunity to game the legal system and yield an oversized award. Unfortunately, we've seen as a result, physicians continue to change the way they practice medicine, usually resulting in an onslaught of medically unwarranted diagnostic testing and referrals to other physicians solely for the protection of the provider, not the patient, under the practice of defensive medicine. We are all aware of the significant and growing cost of health care. Unfortunately, with the understandably defensive nature of the health care delivery system in the United States, we can only expect these strains to multiply as the number of Americans receiving care grows. By empowering physicians with the ability to provide needed health care services without the burden of defensive medicine tactics, an estimated $70 to $126 billion per year could be saved, outcomes could be improved, and utilization of our limited medical resources would be more effectively maximized. Rest assured, I value protection of patients' rights, and efforts to reform the medical liability system should not be misconstrued as an effort to infringe upon those rights. If tragedy occurs, then certainly there should be redress for the individual who has been harmed. Lost sight of the clock up there. There it is. I finally spotted it. I've run out of my time, so I'm going to stop. But thank you all for being here today.
Thank you, Mr. Deal. And for an opening statement, the gentlewoman from California, Ms. Eshoo.
Morning, Mr. Chairman, and thank you for the series of hearings that you're holding as we prepare legislation for health care for everyone in our country. I guess today can be called Doctors' Day, so welcome to all the witnesses. As a nation, we have innovative equipment. I think we have the most knowledgeable doctors. We have the widest array of medicines. But if millions of Americans don't have access to this, obviously something is very, very wrong. And it's worse for minorities and lower income groups. In addition to the 47 million Americans who have no insurance whatsoever, there are millions more who are underinsured. Racial, ethnic, cultural, socioeconomic, and geographical barriers exist in getting people the care they need. And that's why it's critical for us to keep these factors in mind when addressing health care reform, and I think that you're going to teach us a lot today. I look forward to discussing how we can improve Medicaid and Medicare as well. There are parts of the country where 2 out of 3 doctors will not see Medicaid patients. In parts of my own district, and it's the heart of Silicon Valley, so one might think that even though the Gallup poll said that it's the most contented district in the country, we still have many gaps where no doctor will take new Medicare patients because they're reimbursed at rates far below their costs. The Geographic Cost Price Index, or the GIPSI, has severely skewed doctor reimbursement rates so low in Santa Cruz County that many of my senior constituents have to travel an hour or more over a winding mountain road to see a doctor in another county. So this is just one example of how our health care system is broken and fails too many Americans. So I thank each one of you for being here today. I look forward to your testimony, and most important of all, look forward to all of you working with us where in the year 2009, God willing, we'll really reform the system once and for all. Thank you, Mr. Chairman.
Thank you, Ms. Eshoo. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. When I started practicing medicine in the same location 30 years ago, my malpractice premium with the same insurer was $10,000 a year. Today, my premium is just shy of $100,000 annually. Major malpractice reform with bipartisan support should be starting point for our country's health care overhaul. Threat of litigation causes an inestimable amount of practice of defensive medicine. It will not take too many rate hikes for those of us providing obstetrical care in rural county to say enough is enough and that we will not continue to provide high-risk services. These days, malpractice insurance premiums are prohibitive. We have not been able to recruit new doctors in the area, particularly in surgical specialty, due to excessive premium. Addressing medical liability reform and health care reform will free millions of dollars that can be directed toward improving care and access to care. It will also provide for a better distribution of physicians, as the recruitment and retention of physicians is greatly influenced by the medical liability environment of each state. And I have two additional letters, Mr. Chairman, and I ask the unanimous consent that be submitted for the record. They're from doctors in my district and healthcare providers, especially hospitals.
Without objection, so ordered. And thank the gentleman. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, for calling us here. And again, like my colleagues, I want to welcome our physicians here. And just in following my friend from Illinois, if we could handle medical malpractice, and in Texas we wouldn't have 900,000 children that are not covered by SCHIP because the state won't cover the match. Because we have one of the strongest medical malpractice laws in the country, and we still have a huge number of uninsured. I think we have to look at other issues. I want to thank you for holding the hearing today on health insurance and access to care. Houston has the third largest Hispanic population in the country, and I represent an area that is 65% Hispanic and medically underserved. In 2007, nearly half of the 47 million uninsured in the U.S. were minorities. Unfortunately, most minority populations have higher rates of diseases like diabetes, cervical cancer, HIV/AIDS, and heart disease in our community. In fact, Mexican Americans are twice as likely as Anglos to be diagnosed with diabetes. These diseases are mostly preventable, but lack of access to care is still a barrier to the minority communities, in part because of the many health problems for the Hispanic community. As we know on this committee, access to quality primary and preventative care leads to a better quality of life and fewer health problems down the road. And we'll hear today that aside from barriers to primary care, we are facing a shortage of primary care physicians. This is troublesome because even if we reform our system, we may not have enough primary care physicians to serve all the patients who will be entering our health care system. I'm pleased we're addressing the issue of health reform, but as we move forward, we have to reiterate that state and federal partnerships do not work if the state cannot come up with a federal match. Texas, unfortunately, has a long history in the SCHIP and Medicaid program of not providing the matching funds, much to the detriment of our residents. Health reform must be a national level, and if we truly want to cover all Americans, and although many states have their own wraparound programs, some of us do not, and we can't leave those uninsured behind. And again, I want to thank our witnesses today, and Mr. Chairman, I yield back my time.
Thank you, Mr. Green. The gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Thank you for holding this hearing. I feel like I'm in a Chevy Chase movie, doctor, 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 and doctor. But, reading through the testimony today, we're going to have an opportunity to touch on several important issues, and they're issues that have been near and dear to my heart for a long time. I do look forward to discussing the role of Medicare and Medicaid in providing care and the very serious issues we face in ensuring that our primary care workforce is able to meet the demands of the future and the role of health disparities among the various populations. Some very basic questions that we need to consider. How can we think of going forward until we have some solutions to the problems that we know exist within our public systems today? And this hearing might very well serve as a checklist of what we know to be broken within those public systems. The federal programs, Medicare and Medicaid, that cover well over a third of our population are headed for a budgetary collapse. We expect these programs to serve the populations that they do now, and in the very near future to serve even more. And the providers and the workforce face the threat of annual Medicare cuts this year to be programmed to be at 20% unless Congress acts before the end of December, and Medicaid reimbursements that are even worse. And to top it all off, the Association of American Medical Colleges reports that the physician shortage is expected to exceed 124,000 doctors by 25. I am encouraged to see attention being given to the physician workforce issues. I've been concerned about that for some time. In my home state of Texas, the number of doctors between 1995 and 2005 increased by 46%, nearly 5,000 doctors, but the state is still well below the national average. I believe that a good start for Congress is to enact legislation that this subcommittee approved, and we approved in full committee, that I introduced along with Congressman Gene Green, H.R. 914, the Physician Workforce Enhancement Act of 2009, to create additional residency training programs where historically none have operated in the past. We all know doctors are not very imaginative. We tend to go into practice within 50 miles of where we do our training, and this is a bill aimed at capitalizing upon that fact. But it's only one small step. I also represent an area that has a significant minority population who suffers from a lack of direct access to medical services, and obviously the health problems that result therefrom. But that's just it, Mr. Chairman. We need a lot of discussion before we proceed on the path of a comprehensive fix, but we all know we need to proceed. Coverage does not always equal access. Coverage doesn't help the Medicare or Medicaid patient who cannot find a doctor willing to accept the program, or worse yet, a doctor who can no longer afford to keep their doors open because they have accepted what the government will pay. So simply burdening future generations is not the answer. It's up to us. It's up to this Congress. I look forward to the testimony today, and I'll yield back the balance of my time.
Thank you. Chairman of our full committee, Mr. Waxman.
Thank you very much, Chairman Pallone, for holding this hearing. We've already had 2 productive hearings in this series on health reform. At the first hearing, the Institute of Medicine testified that health insurance coverage makes a big difference in personal health. For example, the health of uninsured middle-aged adults who have chronic conditions such as diabetes declines more rapidly than the health of insured adults with these conditions. Overall, uninsured adults are 25% more likely to die prematurely than adults with health insurance. The data are overwhelming. Health insurance improves access to care, which in turn improves personal health. While we also know that health insurance coverage does not necessarily guarantee access to needed care, racial and ethnic minorities often don't get the care they need, even if they are insured. People living in rural areas of our nation have some of the highest rates of chronic health problems like obesity, but some of the lowest numbers of physicians and nurses to address these problems. Communities all over the country, in urban and rural areas alike, face growing shortages of primary care physicians and nurses. Coverage for all is essential, but health insurance by itself won't solve these shortages. We will need additional measures to ensure that we have enough primary care physicians and nurses to meet the nation's needs. As the Institute of Medicine told us, many more low-income Americans would be uninsured today and at greater risk for poor health and premature death were it not for expansions in public programs like Medicaid and CHIP. Medicaid and CHIP are the nation's insurers for low-income families and children and individuals with disabilities. However, just as Americans with private health insurance do not always have access to needed care, so those enrolled in Medicaid and CHIP may not always have access to the care they need. When our committee takes up health reform, we will provide coverage for the uninsured. However, I also want to make sure that our legislation addresses the barriers to access that insurance coverage by itself can't fix. Today's hearing will help us craft solutions that will improve access to care for all, regardless of race, ethnicity, or geography. I look forward to our witnesses' testimony. Yield back the balance of my time.
Thank you, Chairman Waxman. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. Welcome to our guest. And in order to truly reform the nation's healthcare system, I'm one of those that believes we have to focus on cost reduction improved quality, increased access to all Americans. True medical liability reform is a critical component of the health reform debate. It is concerning to me that there has been little attention on how tort reform will affect access to care in the broader health care reform debate. The lack of liability reform hurts patients, hurts our constituents, impacts their ability to receive care due to enormous added cost incurred in the practice of defensive medicine, which has driven trial lawyers looking to cash in on what they deem to be bad outcomes. Any attempt to make health care available to the underserved and uninsured will be doomed to failure if the legal costs of practicing medicine are not addressed. With reimbursement issues added to the high cost of liability insurance, physicians, who are often small business owners, must weigh the risk of taking new patients, particularly the uninsured, if cost exceeds reimbursement. A physician in my district recently told me, without significant and real tort reform, no plan to control increasing healthcare costs will succeed. While it is healthy to consider the best practices for both patients and physicians, the debate must be resolved so the medical system can operate in a more effective fashion and be improved to consistently deliver high quality of care. Mr. Chairman, I'd like to ask unanimous consent that I enter some letters into the record from physicians in my district who have highlighted their concerns with the need for malpractice reform, medical malpractice reform in the overall debate.
Without objection, so ordered. Thank you,
back.
gentlewoman. Chairman Emeritus, Mr. Dingell.
Thank you, Mr. Chairman, and I commend you for holding today's hearing on improving access to health care. This is a particularly timely topic since this is cover the uninsured week. There are 46 million people in the United States who lack health insurance, and some have estimated that without action, the number could reach 61 million by 2020. It comes as no surprise that the uninsured have trouble assessing quality health care, but access is a problem even for those with insurance coverage. The high costs of health care and lean insurance benefits have led more than 25 million people to be classified as underinsured. These people are more likely to forego needed care because of costs. Furthermore, the Commonwealth Fund reports that in addition to gaps in insurance coverage, American patients lack timely access to care, meaning they are not able to see their doctors in 2 days of becoming sick. As we move forward with comprehensive health care reform legislation, there are a few key issues that we must tackle with regard to expanding access to care. First, and most important, we must set a goal that our health care reform bill moves us towards universal coverage. That is why I support a provision that would require everyone to have health insurance. However, we must ensure that care is affordable to everyone, and I believe that is the only way we can have universal coverage and have it in a fair and proper way. Even if we require everyone to have health insurance, many Americans will still lack access to health care due to a shortage of primary care providers. Strong primary care systems have been shown to reduce costs and improve quality. However, of the 800,000 physicians in the United States, only 40% are primary care providers. By the year 2025, we will have a shortage of over 40,000 primary care doctors. Our health care payment systems have essentially subsidized specialty care. As we construct new health care networks, one that I hope includes a public plan, that must include a public plan, we must move from a fee-for-service payment structure to one that records quality and patient-centered primary care. We must consider incentives such as loan forgiveness, scholarships, and other things to draw young medical students into the primary care field. Additionally, we must assess the need for nurses, nurse practitioners, and physicians' assessments, and we must then invest in a proper way of ensuring that that carries forward. These professionals serve on the front line of care and play a critical role in primary care and prevention. We must address the persistent disparities in health care access and health outcomes for racial and ethnic groups. Numerous studies have shown that racial and ethnic minorities are consistently less likely to receive necessary care, even when controlling for other access-related factors. I believe, and I stress this, that health care is a right, not a privilege, and failure to address the root causes of these disparities is immoral. Finally, if it were not for Medicare, Medicaid, and CHIP, many people would be among the ranks of the uninsured and underinsured. These public programs serve 1/3 of U.S. populations. Any comprehensive reform must ensure the viability of these programs. I thank you, Mr. Chairman. I yield back the balance of my time.
Thank you, Chairman Dingell. Next is our ranking member of the full committee, Mr. Barton.
Thank you, Mr. Chairman. Appreciate you holding this hearing on issues related to improving the access to care. This is the third hearing, and as our witnesses will testify, improving access to health care involves many issues, such as getting more people into the provider workforce, the role of public health programs, and perceived health disparities. I'm particularly interested in hearing about the role of medical liability reform as it relates to health care access. Also about the role physicians can play to increase access points in their communities. The current medical liability system in the United States affects the ability of patients to receive care when they need it. It's well documented that doctors are scaling back the care they provide or abandoning their practice altogether to avoid being sued. When you don't have providers, that can mean the difference between life and death for those patients who don't have a doctor. My home state of Texas is a perfect example of how medical liability reform improves people's health care. In 2003, Texas voters approved a constitutional amendment that included a limit on non-economic damages while continuing to allow injured parties to be fully compensated for economic damages. Prior to that reform, skyrocketing insurance premiums were forcing doctors to flee the state, quit medicine, or cut back on complex life-saving procedures. At the height of the crisis, Texas ranked 48 out of the 50 states in per capita physicians. In the years since the reform was passed, Texas has been transformed from a state in turmoil to a model. Doctors are coming back to Texas. Patients are getting better care. More doctors mean improved access, especially for those Texans that are living in poor and medically underserved areas. I would urge this committee, Mr. Chairman, to take a serious look at liability reform as we move into the overall issue of health care reform. I also believe that we should look at what is working in the communities across this country to increase access to care. Last year we heard from a doctor in Louisiana whose community was ravaged by Hurricane Katrina. Hospitals were closed and residents were without access to needed medical services. Physicians in that community came together to run a physician-owned hospital that provided the quality of medical care that residents so sorely need. Now, I know it's not the popular conventional wisdom to suggest that people helping their community can make a difference without the bureaucrats in Washington telling them what to do, but it is true. Who knows what happens when communities actually work together themselves and don't look to Washington for the solutions. It is certainly not the Washington elites who have all the answers. We should applaud the people who have stepped up to the plate and expanded access to quality medicine in their own neighborhoods. This committee has a long history of being involved in the issue of physician-owned hospitals. These facilities have consistently demonstrated that they provide high-quality care for patients and achieve high patient satisfaction. Patients like receiving their care at these facilities. Physicians and nurses like working at these facilities, and these facilities continue to top the charts in terms of health care quality. You don't have to take my word for it. Visit any physician-run hospital and you can see for yourself. I would extend an open invitation to anybody on this committee to come to my district and visit a number of physician-owned hospital facilities in my district if they don't have them in their own district. When physicians have a stake in the system, they raise the standard of quality care to a level that patients then expect and demand from all providers. As we discuss access to care today, we need to keep this in mind. We should be expanding the number of providers, not limiting the number of providers. Again, I appreciate you, Mr. Chairman, for holding this hearing. I have a letter from a doctor-owned hospital in my district, USMD, dated yesterday to myself by the chairman of the board that I would like to submit for the record if we could get unanimous consent.
I'm sorry, what is it that you want to submit?
A letter from a physician-owned hospital in my district.
Without objection, so ordered.
Thank you, Mr. Chairman.
Thank you. Our full committee vice chair, Ms. DeGette.
Thank you very much, Mr. Chairman. This is a very important hearing in healthcare access on all levels, and I'm looking forward to hearing the testimony from our panel. I wasn't going to talk about this, but it appears to be in the talking points for my friends on the other side of the aisle. So let me just mention that we did address the issue of medical malpractice reform and the concept of federalizing these traditionally state tort claims in the 109th Congress. And we had a number of hearings in that Congress about this subject at which we took testimony. And frankly, there's absolutely no evidence that if we federalized these torts and we enacted caps on compensatory damages, that would help bring the cost of medical care down in any way. I do think that though we need to address the issue of what's happening with doctors' insurance rates, because doctors' insurance rates have consistently increased over the years, even in states like my state and Texas and other states where we have had caps on non-economic damages for some years. And I think we need to put all of this into the mix. But I think it's unfair to try to claim that we haven't addressed this, that we haven't looked at it, or that medical malpractice rates are causing the terrible cost overruns that we have in our system. Thank you, Mr. Chairman.
Thank you. The gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman, and thank you to all the doctors present here. We have enough to open a sizable hospital, I guess. Who's minding the patients? All of our concern is to improve access to care, and I believe that has to include
Is your microphone not working?
It was going off and on, sir. I don't know if maybe someone on that side of the aisle is. But don't do that to me, because I agree. I agree. Hold the clock there, too.
We'll try. Go ahead.
Thank you, Mr. Chairman. I'm concerned about some of the inefficiencies that we put into the system itself, which drives providers away. And such as, why aren't doctors more willing to be Medicaid and Medicare providers? Why are the rules we set forth a problem? Why does a person diagnosed with multiple sclerosis have to wait 2 years before they can be given medication? Why don't we pay for disease management of a diabetic but are willing to pay to have their legs amputated when they have complications? Why don't we pay an oncologist to do lab work on the day of chemotherapy if they're trying to determine if a patient can have that chemotherapy? There's so many questions that we have in this area that I think are barriers to access, and I'm hoping that as part of the testimony we hear, it will include how we can improve the health system the government runs through the Medicare, Medicaid, and VA system, and learn to take down the barriers that stand in the way of access to care. Thank you very much.
Gentlewoman from California, Ms. Capps.
Thank you, Mr. Pallone, and thank you to each of our witnesses today. We have a stellar panel here, and thank you for coming. This hearing is really central to our debate on how we're going to improve health care. If we can improve the way we care for the most marginalized in our society, then we can certainly improve the way we care for everyone. One of the barriers to access today is a lack of health professionals, nurses, physicians, dentists, a whole array of them. And contrary to what some of our colleagues on the other side have said about everyone supposedly being able to obtain health care at the emergency room, there aren't even enough health professionals to staff many emergency rooms 24/7 and 7 days a week. So as we talk about ways to improve access for everyone, let's talk about what else we can be doing to educate more health professionals and get them into the areas where they are needed most. I look forward to the testimony. I yield back.
Thank you. Gentleman from Michigan, Mr. Rogers.
Thank you, Mr. Chairman. Thanks to the panelists. Like you, I believe we must take action to provide more Americans with access to affordable, high-quality health insurance. But the details on how we get there are important. About 15% of Americans go without health insurance for some period of time every year. At the same time, 85% of Americans have health insurance, and for many of this 85%, they have good coverage that provides for their family's needs. We must focus on the 15%. Who are they? How can we ensure that they have access to affordable insurance? In reality, a large portion of this group is young and goes without insurance by choice. A large part of this group is already eligible for government programs, but not signed up. How should we address these issues? In finding solutions to address the 15% problem, we must be careful not to destroy a system that does work for tens of millions of Americans. I'm concerned that some proposals addressed today would do just that. Forcing millions of Americans who already have health insurance to accept fewer benefits, reduced access, and higher costs is hardly a solution. I believe we can find solutions to provide universal access to health care, lower costs, and better quality for all Americans. I believe we can strengthen critical safety net programs like Medicaid, Medicare, and S-CHIP, but we must work together to achieve this goal. Mr. Chairman, I look forward to working with you and the members of this committee on this important issue, and I yield back the remainder of my time.
Thank you. Gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. It is notable that we're holding this hearing on ensuring access to care during Cover the Uninsured Week. We are discussing two issues today that are very close to my heart: health disparities and primary care workforce shortages. On health disparities, the level of inequality in our healthcare system is a shocking injustice. Thanks to several of my colleagues, we have recently focused greater attention on racial and ethnic health disparities. I also want to draw attention to the fact that the lesbian, gay, bisexual, and transgender community also experiences significant health disparities. Most well known as an issue, of course, is HIV/AIDS, but the LGBT community experiences other health care disparities as well. We are far less likely to have health insurance compared to our straight counterparts. LGBTQ youth are up to 4 times more likely to attempt suicide than their heterosexual peers. And we also know that many delay care due to fear of discrimination, leading to higher mortality rates from heart disease and cancer. To address these disparities, I'm developing legislation that I will offer later this year. Let me quickly also express my strong concern about our existing and looming primary care shortages. To address one small aspect of this problem, I offer bipartisan legislation that would provide reimbursement for the cost of graduate degrees in nursing in exchange for a commitment to teach nursing for at least 4 years. Without the worry of educational debt, nurses will be able to devote time to training the next generation of the frontline primary care workforce. Thank you again, Mr. Chairman, and thank you to our witnesses today.
Thank you. Gentleman from Kentucky, Mr. Whitfield.
Thank you, Mr. Chairman, and I want to thank the panel, and particularly for listening to all of us this morning. And we've heard a lot of discussion today about liability insurance, and whatever needs to be done to correct that problem, we may have differences of opinions about it, but I think it is imperative that we focus on the fact that there is a problem. Members of the Kentucky Medical Association left my office just a few days ago, and they referred to the study in Massachusetts that showed that 83% of doctors practice defensive medicine, and almost 28% of the tests, procedures, referrals, and consultations were ordered to avoid lawsuits. And then almost half of America's medical students in their 3rd or 4th year of medical school have indicated the liability crisis was a factor in their choice of specialty, threatening America's future access to high-risk medical services such as surgical and other specialties. So I think it's something that we must focus on as we move forward on health care reform. Thank you.
Thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Chairman Pallone, and thank you again for this series of hearings that continue to inform and guide us as we prepare to reform health care this year. Today we're looking at access and several barriers to it. It is important to understand that while providing coverage is the linchpin of reform, it's not the only thing that must get done to to ensure access. We must have more and more diverse providers at all levels. We need to stop the way malpractice is increasing costs and forcing doctors out of practice. And as you will always hear from me, we must eliminate disparities and ensure that the system we create ensures equal access to quality care for every American. I want to thank the panelists for the work that they have been doing to show us the way forward, and I look forward to your testimonies. I yield back.
Thank you. Gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. Before I waive my opening remarks, I want to ask unanimous consent to submit for the record a letter, Mr. Chairman, from the Medical Association of Georgia Mutual Insurance Company to the Medical Association of Georgia on the question of, is tort reform working in the state of Georgia? The response, most definitely. I ask unanimous consent to submit this letter for the record.
Thank you. Without objection, so ordered. I do want to, if all of you could give me these letters, though, so we could take a look at them, I'd appreciate it. Because I know I'm always concerned that we're going to have too much for the record, but I know I think you only had a few in each case. Yes, Mr. Deal.
In that regard, I would ask unanimous consent to include in the record the American Medical Association two-page statement on medical liability reform, and also a two-page letter from Richard Scott on behalf of Conservatives for Patients' Rights. I would ask unanimous consent to include those in the record.
Without objection, so ordered. Thank you.
Thank
you. Next is gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman. First of all, I want to say to the witnesses, I thought your written testimony was outstanding and very, very helpful as we proceed on our health care reform effort. I believe it shows that a consensus is building that broad-based, basic primary care reform, those simple visits to the doctor's offices and clinics, will be central to providing affordable access to health care for all American families. Dr. Mullen, your workforce analysis was particularly terrific, I thought, and your recommendations to improve primary care professionals very helpful, along with Dr. Harris's recommendations for a national health care workforce policy. Thank you for highlighting the arbitrary and outdated caps on physician-resident slots that's really harming high-growth states like mine, the state of Florida. You also had constructive recommendations on the primary care pipeline. I want to thank your organization for endorsing my bill, the Primary Care Incentive Act, that provides that tuition reimbursement for folks that go and work in community health centers and clinics and devote a number of years of community service. Dr. Lovizo-Mori, you also had some very creative solutions, also picked up on a lot of the workforce issues that Congresswoman Capps has taken the lead on in nursing, physician assistants, and I appreciate that. Dr. Smedley, your analysis and statistics were very eye-opening and just demonstrated how health care is really our civil rights struggle for our time. Thank you, Mr. Chairman.
Thank you. The gentlewoman from North Carolina, Ms. Myrick. Your waves. Gentleman from Connecticut, Mr. Murphy.
Thank you very much, Mr. Chairman. We're going to talk a lot over the course of the next few months about making sure that people have insurance, but I know today we're going to spend time on what should be our second priority, making sure that people that have insurance actually have access to care. And I'd like to just share one particularly important story from Connecticut. Last year in Tolland, Connecticut, in eastern Connecticut, about 190 dentists got together and decided to provide free care over the course of 2 days. The night before that clinic began, there were dramatic torrential thunderstorms. Through the night, dozens of people lined up, soaking overnight, waiting for care the next morning. And their individual stories, which numbered 700 by the time that clinic was done, are shocking but unfortunately too common. There was a mother whose children, insured through our state's SCHIP program, Husky, had been waiting 8 months to see a dentist for immediate care. There was the single woman who worked 2 jobs, had insurance, but whose deductibles were so high she couldn't afford to see a dentist. And there were the unemployed workers there on COBRA whose employers never offered dental coverage in the first place. This is just one story that aren't not original to Connecticut, but they do illuminate a point. Just because you have health insurance doesn't mean that you get to see a doctor, doesn't mean you get to see a dentist. Health insurance without real access is little better than no insurance at all. I thank the panel for being here, and I look forward to your testimony today.
Thank you. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman, for holding this important hearing, and specifically as it relates to rural health care disparities. I had a chance to review some of the testimony for today, and I couldn't help but being struck by some of the statistics highlighted by Dr. Kitchell from Iowa in his testimony. 20% of the nation's population resides in rural areas, yet 9% of our nation's physicians reside in rural areas. Rural physicians see up to 30% more patients per physician. The cost of running a rural physician's practice is considerably higher than running an urban or suburban city or physician practice. And the rural physician's expenses, despite being greater, their Medicare reimbursements are far less. It's no wonder that some of the counties that I represent have 1 or 2 practicing physicians serving the entire county, requiring many of my constituents to drive long distances for basic care, and that doesn't even cover the specialists. While the primary care focus is one that we need to be concerned with, it applies to other realms in the medical or healthcare delivery field as well. Healthcare or home health nurses, medical assistants, and other professionals are in short supply. One of the critical elements of this issue is the impact that it will have on our economy. Developing and training a workforce to meet the needs that are glaring in rural America right now will not only enhance quality health care or enhance access to quality health care, it will provide an important avenue for economic opportunity in an area of the country that desperately needs it. So I'd like to thank those who have come before the committee this morning and look forward to hearing all your testimony.
Thank you. The gentleman from Iowa, Mr. Braley.
Thank you, Chairman Pallone. I've been looking forward to this hearing because access to care is a primary concern of mine and a primary concern of healthcare providers in Iowa and their patients. Our current system has built-in inequities which result in a lack of access to care for residents in many rural states like Iowa, as my colleague from Ohio has just pointed out. A glaring example of this is the Geographic Practice Cost Indexes, or GPCIs. These antiquated formulas ensure that some parts of the country receive drastically lower Medicare reimbursement rates than other parts, and that has led to a critical shortage of doctors in some parts of our country. Despite the well-documented efficiency and quality of Iowa's healthcare system, Iowa healthcare providers still lose millions of dollars because they choose to care for Medicare patients. There's already a physician shortage in areas of Iowa, and the existence of the GPCIs is a strong disincentive to those who often need it most, Medicare patients. Last Congress, I introduced the Medicare Equity and Accessibility Act, which addresses the GPCI problems. I'm going to continue fighting for a solution to the GPCIs, but in fact, this is only a Band-Aid for a broader problem of disparity of care in rural areas. I look forward to hearing more about access to care in rural areas in today's hearing. And I also want to welcome my friend Dr. Michael Kitchell to the witness panel today. Dr. Kitchell is currently the president-elect of the Iowa Medical Society and someone I rely upon for sound advice on healthcare policy issues. He's also an expert on policies surrounding rural health care, and I want to welcome him and look forward to his testimony. Thank you.
Thank you. The gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. There's obviously enormous expertise on the panel, but there's expertise on this subcommittee too, and I surely hope we will pull together and craft an excellent bill that addresses this important subject of access. Access is tough for the insured and uninsured, especially in California where low reimbursement for Medicaid is pushing more and more doctors out of the program. In my district, we're lucky to have places like the Venice Family Clinic that provide free, quality health care to low-income minority population that lacks private coverage. 81% of the patients seen at the clinic are minorities, so the clinic places an emphasis on volunteer translator recruitment and medical tutorial programs. Remarkable volunteers are the arteries that keep the clinic going. My late father, a physician, devoted his time and passion to serving 3 generations of patients. Like father, like daughter, and as a former VFC board member, I'm a huge supporter of their work. As the nation's largest free clinic, 24,000 patients last year, this is the only place for most of its patients to access care, helping them to avoid emergency room visits and other serious consequences. Unfortunately, many places in the country don't have Venice Family Clinics, and that's a model that we should try to include as we draft the access part of the bill. Thank you, Mr. Chairman.
Gentleman from Georgia, Mr. Barrow.
Thank you, Mr. Chairman. When we talk about access to health care, we're talking about different things to different folks. In rural parts of the country, the problem is physical access. You got specialist doctors and nurses that don't want to practice in rural areas, but you also have groups who live in those areas who are slower to seek care in the first place. You got a combination of an underserved community of high-risk patients. That's a bad combination. On the other hand, you have access problems that are financial in nature, and we have different programs to try and make health care available to different groups of folks. We got Medicaid for the poor, we got Medicare for the elderly, we got programs like S-CHIP for the kids of folks who make too much to qualify for Medicaid, but not enough to get insurance on their own. There's another group that's underserved for whom the cost of health care isn't altogether out of reach, but it's just out of reach, and as a result, it might as well be altogether unavailable. And that's folks who can't afford to pay the price differential that the insurance industry charges them because of the groups, the size of the groups they happen to lump them into. You're in a smaller group, it costs you more to get the same health care package or benefits than it does for folks who are members of larger groups. The legislation I introduced in the last Congress, the SHOP Act, the Small Business Health Options Program Act, addresses this price disparity in ways that I think will make health insurance available to more folks who can afford to kick in for the cost of care they're drawing out rather than drawing out care at the emergency room without kicking in at all. So I hope we can explore ways and means of making health care more affordable to folks just by eliminating the price differential that folks got to pay for the same benefits package. Thank you, Mr. Chairman. I yield back.
Thank you. Gentleman from Texas, Mr. Gonzalez.
Wave opening. Thank you, Mr. Chairman.
Thank you. I think we've covered everybody here for opening statements. So we'll now go to our panel. I know you've been waiting patiently, and we appreciate that. I want to welcome everyone, and let me introduce you, starting on my left here. First is, and they're all doctors, everyone. Dr. Brian Smedley, who is Vice President and Director of the Health Policy Institute, the Joint Center for Political and Economic Studies. Dr. Michael John Kitchell, who is President-elect of the Iowa Medical Society, the McFarland Clinic. Dr. Michael Sartorius, Professor and Chairman of the Department of Family Medicine at the University of Nebraska Medical Center. And from my home state of New Jersey, welcome, Dr. Liza Mori, who is President and CEO of the Robert Wood Johnson Foundation. And then we have Dr. Fitzhugh Mullen, Murdoch Head Professor of Medicine and Health Policy and Professor of Pediatrics at the George Washington University. Dr. Jeffrey Harris, President of the American College of Physicians. Dr. James Bean, who is President of the American Association of Neurological Surgeons. And Dr. Diane Rowland, who is Executive Director of the Kaiser Commission on Medicaid and the Uninsured. Now, I'm told that you don't actually have a timer down there, so you won't know when the 5 minutes are up. That's the only thing more dangerous is when we don't have timers up here. But please try to stick to the 5 minutes if you can, and of course the statements become part of the record. And we'll start with Dr. Smedley.
Thank you, Mr. Chairman. I appreciate the opportunity to provide testimony on racial and ethnic disparities in healthcare access and quality. For nearly 40 years, the Joint Center for Political and Economic Studies has served as one of the nation's premier think tanks on a broad range of public policy concerns for African Americans and other communities of color. We therefore welcome the opportunity to comment on strategies for addressing healthcare disparities. As the committee has pointed out, healthcare disparities are differences in access to and the quality of healthcare experienced by racial and ethnic minorities, immigrants, those who aren't proficient in English, those who live in rural communities, and many others relative to more advantaged groups. Left unaddressed, these disparities have the potential to unravel even the best efforts to contain healthcare costs and improve the overall quality of care. In addition, their persistence leaves U.S. healthcare systems poorly prepared to address the needs of some of the fastest growing segments of the population. This morning, I'd like to briefly examine the causes and consequences of racial and ethnic healthcare disparities and offer some policy strategies for their elimination. As I hope to illustrate, these disparities are unjust and avoidable. I'll therefore refer to them as inequities throughout the remainder of my testimony. Healthcare inequities are not new. They're a persistent relic of segregation and historically inadequate healthcare for communities of color. Like access to other opportunities, healthcare for minorities suffered from government inattention for over 100 years after the end of the Civil War. Even less than 45 years ago, minorities routinely received inequitable care in segregated settings if care was received at all. Today, healthcare is much more broadly available, but the contemporary context remains shaped by this history. I want to note at the outset that while healthcare access and quality disparities are unacceptable, they are not the most important factors that contribute to the widely divergent health status of America's racial and ethnic groups. Some groups, particularly African Americans, American Indians and Alaska Natives, and Native Hawaiians and Pacific Islanders, experience poorer health relative to national averages from birth to death in the form of higher infant mortality, higher rates of disease and disability, and shortened life expectancy. A large and growing body of public health research demonstrates that to address these problems, we must improve the social and economic contexts that shape health. As the World Health Organization's report on social determinants of health states, inequities in health and avoidable health inequalities arise because of the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. It's clear that many Americans, disproportionately racial and ethnic minorities, face healthcare access and quality inequities. Some of these inequities can be explained by socioeconomic factors, while others cannot. The National Healthcare Disparities Report, which is prepared and released annually by the Agency for Healthcare Research and Quality, has found that African Americans, Hispanics, American Indians, and Alaska Natives fare worse than whites on a preponderance of measures of healthcare access and quality. For example, the report finds that minorities are less likely to receive even routine evidence-based procedures and experience greater communications barriers. Now, the NHDR provides a window to the healthcare experiences of a diverse patient population, but it does not disentangle the influences of race, income, and insurance on health care. A substantial body of evidence, as has been pointed out, demonstrates that racial and ethnic minorities receive a lower quality and intensity of health care than white patients, even when they are insured at the same levels and present with the same types of health problems. Many factors contribute to these inequities, and these often interact in complex ways. I'd like to focus on an important underlying factor in healthcare inequality, and that is residential segregation. Racial and ethnic minorities are more likely than whites to live in segregated, high-poverty communities, communities that have historically suffered from a lack of healthcare investment. Institutions that serve communities of color are more likely to experience quality problems and have fewer resources for patient care than institutions serving non-minority communities. Just as an example, a recent study of African American and white Medicare patients found that the risk of admission to high mortality hospitals was 35% higher for blacks than for whites in communities with high levels of residential segregation. Racial and ethnic segregation and inequality therefore set the stage for inequitable health care in the United States. To solve these problems, we must prioritize and invest in improving the health of communities that suffer from health care inequities. To make the largest gains, we should improve social and economic conditions for health. For example, the federal government should enforce provisions to address environmental justice in minority and low-income communities, and should establish health empowerment zones in communities that disproportionately experience disparities in health status and health care. To improve health care access and quality for communities of color, the federal government should improve access to health care providers, as many on the committee have pointed out. We need to make special efforts to ensure that health care resources are better aligned with these communities' needs. We can do so by increasing the diversity of our health professionals, providers, supporting safety net institutions, providing incentives for providers to serve in underserved communities, and addressing the geographic imbalance of healthcare resources by expanding, for example, community health centers. We can also promote equal high-quality access to care by collecting and monitoring data on disparities and publicly reporting these data. We can also encourage the adoption of cultural and linguistic standards and encourage attention to disparities in quality improvement initiatives. Mr. Chairman, my time is short. These are but a few of the many ideas that will be put forward today, and we look forward to working with you as you craft legislation to address these issues.
Thank you, Dr. Smedley. Dr. Kitchell.
Thank you, Chairman Pallone, Ranking Member Deal, and Congressman Braley for inviting me. I practice neurology in a 167-member physician-owned multi-specialty clinic in central Iowa. We have offices in 21 different sites in rural Iowa, and we have about 1 million patient visits per year. Maintaining access in rural America is difficult because of physician shortages, long distances to travel, and fewer services that are available. You'll hear other speakers today that will talk about the shortage of physicians in certain specialties, for example, internal medicine. In Iowa, we actually have 3.7 times fewer internal medicine physicians as the state of Massachusetts. And if you aren't aware, Massachusetts has recently declared a critical shortage of 12 different specialties, including internal medicine. So if those shortages in Massachusetts are critical, when we have 3.7 times fewer internists, I'd say we're just about comatose. The Medical Economics Survey has actually shown that rural physicians' practice expenses are higher in their survey. They are higher than inner city, suburban, and urban physicians. The main reasons for practice expenses being higher in rural areas is the number of patients that we see. When you have half as many physicians in rural areas, you got to see a few more patients. Rural physicians are paid less by Medicare for our work, despite the fact we work longer hours. Medicare pays rural physicians less for practice expenses, despite the fact that Medicare has never done a survey of the actual practice expense differences for physicians in rural areas. This has been going on for 17 years. Medicare pays us less for e-prescribing. You know, I looked for a geographic discount on electronic prescribing equipment, and I couldn't find any geographic discounts. I looked for geographic discounts on office equipment, computers, and yes, even electronic medical records. And you know, I couldn't find a geographic discount on electronic medical records. Medicare also pays us less for quality, and Congressman Braley has been kind enough to sponsor a bill to eliminate the devaluation of quality. Medicare pays quality for physicians at a lower rate in rural areas. I think that that devaluation of quality is the ultimate insult to rural physicians. Some rural Medicare fees are as low as 1/3 of what our private insurance payers are paying us. Some healthcare services are delivered at a loss in rural areas because Medicare pays so little. If Medicare expanded, or if Medicare would cut their payments, obviously there will be more losses of dollars, more losses of services. You can't make up on volume when the cost of the service is greater than what you're paid. Congressman Braley, Senator Grassland, Senator Harkin have all sponsored legislation to eliminate or at least reduce these geographic penalties. President Obama in October also has come out in support of geographic equity. I hope that you will also come out in support of geographic equity. A lot of what's wrong in healthcare, though, is due to the physician payment system. This physician payment system is called the resource-based relative value unit system. That is, our payment system pays for resource use. It should be no surprise then when we pay for resource use that we have the most expensive healthcare system in the world. When we pay for more expenses rather than pay for the most the most effective care, we're going to get more expensive care, and we won't get as much cost-effective care. We need to pay for value, not geography. We need to pay for things that matter to the patient. We need to pay for the right tests and treatment, not just more tests and treatment. Iowa is a good example of a high value in healthcare. It shows that high-quality healthcare doesn't have to be so expensive. The Commonwealth Fund has rated Iowa's healthcare system as #1 in children's care and #2 for care of adults. The Agency for Healthcare Research on Quality, Dartmouth, and other researchers have consistently shown that Iowa and Midwestern states take the lead in quality and cost-effective care. I testified 6 years ago at the Senate Finance Committee and the National Health Policy Forum, and I urged that Medicare pay for value, not volume. I urged that Medicare pay for quality, not quantity. Unfortunately, over the last 6 years, there hasn't been much progress made in paying for value or paying physicians for quality. The Medicare payment system for quality is called Physician Quality Reporting Initiative, or PQRI. PQRI is definitely a failure. Only 8% of the nation's physicians succeeded with this program. PQRI does not reward quality. It simply rewards reporting. The lowest quality physician in this country could report correctly on 3 quality measures that they never did any of those measures, and they would get the bonus.
Doctor, I hate to interrupt, but you're a minute over, so if you could wrap up.
Medicare's hospital quality rewards program is a success because it measures larger groups and systems. So what should Medicare do to reward quality and value for physicians? Another lesson that can be learned from Iowa is about coordinated care, teamwork, and accountability. Quality measures should be based on teams, groups, and systems. We need to encourage all physicians to be part of a system. Middlesex County, Connecticut is a good example of independent physicians getting together, improving quality, improving value, and being accountable. We need changes in the payment system for geographic equity to reduce costs and increase quality and value. Thank you, Mr. Chairman.
Thank you. Dr. Sartorius?
I'd like to thank you, Mr. Chairman, for conducting this subcommittee hearing on the accessibility of health care. I'm here to share information about the Bellevue Medical Center, which is currently under construction in Bellevue, Nebraska, a suburb of Omaha. The Bellevue Medical Center is an entirely different entity than anything we have seen across the country. It's going to be a full-service community hospital providing a wide array of services, including emergency services 24 hours, to one of the largest communities in the United States without an acute care hospital. It is majority owned by the largest public hospital system in the state and is expected to open in April of 2010. This medical center illustrates how hospitals, doctors, and communities can come together to enhance the access of health care to populations in need. I believe the Bellevue Medical Center represents the best in American health care. When we open our doors next spring, we'll be an example of a public hospital system, a group of committed and talented physicians, a supportive city government, and a thriving and responsive business community that came together to make health care accessible to an underserved population. Bellevue is the 3rd largest city in Nebraska. It's about 45,000 residents, and it is home to Offutt Air Force Base and the United States Strategic Command. Approximately 10,000 active duty military personnel, 20,000 dependents, and 11,000 military retirees live in the Bellevue area. It's a very important asset to the Bellevue community. It may come as a surprise that Bellevue has not currently or has ever had a community hospital or emergency room in the city. The Offutt Air Force Military Hospital, Erlen-Bergquist, closed in 2005 as part of the Base Closure Realignment Commission. Though clinics remain at the Erlen-Bergquist Hospital, the remaining same-day surgery and evening urgent care clinics will be closing in the fall of 2009. As a family physician, I can see firsthand the need for a hospital in Bellevue. There's approximately 180,000 people in eastern Nebraska and western Iowa who would benefit from this hospital and will in 2010. Currently, all of the rescue squads in the Bellevue community leave that community for access to emergency care. Low-income individuals benefit from this full-service hospital as well. The UNMC physician group currently has a clinic in the Bellevue area which serves a significant low-income and Hispanic population which live in the near South Omaha area. This hospital will provide access to care that is currently not available to that population. Furthermore, I have a unique vantage point on the medical needs in this area. As chair of the Department of Family Medicine, we have had an affiliated family medicine residency training program with the Air Force since 1992. Unfortunately, with the closure of that base hospital in 2005, it has made difficult some of the training opportunities for 1/5 of the Air Force family medicine residents in their training programs. It is then important that we combine that military training need with the needs of the population to come up with the idea for the Bellevue Medical Center. The center is a creative solution to address the healthcare needs of the community of which it is serving. The Bellevue Medical Center is aligned with an academic medical center, the University of Nebraska Medical Center and the Nebraska Medical Center, faculty physicians, community physicians to meet community needs. When it opens in April of 2010, it will be a full-service hospital delivering adult care, pediatrics care, labor and delivery, emergency care, inpatient and outpatient surgery, and intensive care. This represents a collaborative model involving public, academic, community physicians, and community leaders. The Bellevue Medical Center will hold strongly to the values of the existing Nebraska Medical Center for its excellence, innovation, and quality patient care. In addition, it will serve as an educational mission for the medical center. It will train 20% of the Air Force complement of family practice resident physicians and will allow training in 2 different locations, the Tertiary Care Academic Medical Center and the community-based Bellevue Medical Center in 2010. And in this time of economic downturn, this project also has created jobs. In addition to the hundreds of construction jobs already created, the Bellevue Medical Center will employ 600 FTEs when open. The Bellevue Medical Center has strong community support. In fact, the community is extremely engaged and led the effort to make this Bellevue Medical Center a reality. I believe the Bellevue Medical Center can serve as a healthcare model for other communities. The nation's healthcare system needs to encourage innovation through partnerships. In our case, an academic medical center partnered with faculty physicians, community physicians, and the community. I would encourage other academic medical centers to consider to replicate what the Nebraska Medical Center has done in the Bellevue community. Moreover, the Bellevue Medical Center is also a model as it relates to the care of our military service members, their families, and military retirees. It is our position that our military service members, their families, retirees, deserve the best quality of health care possible from a nearby community hospital. The Bellevue Medical Center will be able to provide that care. This center will also care for all of the benefits provided under the TRICARE program. The Bellevue Medical Center will accept and looks forward to working with the TRICARE patients. In conclusion, as Congress begins to tackle health care reform, access to health care must be a significant part of any solution. I'm proud to say that the Bellevue Medical Center stands ready to be part of that solution to expanding access to health care. We're excited that your subcommittee has asked us to share our story with you this morning. Thank you for your attention and interest, and I'll be happy to answer questions when we get to that point.
Thank you, Doctor. Dr. Levi-Zomori.
Thank you, Chairman Pallone and Ranking Member Deal, and members of the subcommittee for this opportunity to testify. As has been mentioned, it is Cover the Uninsured Week, and communities all across the country are calling for fixes to our broken healthcare system. Expanding coverage must be a priority as Congress considers opportunities for health reform, but this alone will not fix the problem. In my written testimony, I've touched on issues of healthcare disparities and non-financial barriers to health, but I'd like to focus my oral remarks on the role of nurses in ensuring the access to high-quality care and opportunities for addressing the shortage of nurses and nurse faculty. If you've ever been hospitalized or had a loved one who was hospitalized, you know that nurses make a difference. Nurses' vigilance keep bad things from happening to patients. Their actions prevent medical errors and infections. They keep patients safe from falls and from the complications of extended bed rest. They also work in community settings to prevent disease, help patients manage their diseases better, and avoid unnecessary hospitalizations. As Congresswoman Capps noted recently at the White House Forum for Health Reform, there's a projected shortage of 500,000 nurses by 2020. The nursing shortage results from a confluence of factors: a shortage of nurse faculty, too few nurses enrolling in nursing programs, and turnover among experienced nurses. There's a vacancy rate of 7.6% among nursing faculty, which results in far too many qualified students being turned away. Solving this problem will require action at the national level and a commitment of resources, both public and private. The results of our grantees and partners' work suggest that the following steps must be taken. First, we need to increase the number of nurses with baccalaureate degrees to create a larger pool of nurses who will qualify to pursue faculty careers. Second, we need to increase financial assistance to enable more nurses to attend graduate school and obtain teaching qualifications. Third, encourage private sector to adopt evidence-based practices, including the use of technology that will improve the retention of nurses in their clinical roles. And finally, we need to support research to demonstrate the nurses' role in improving the quality of patient care and improving outcomes. It is also essential that funding for workforce development not ebb and flow with yearly changes in appropriations to Title VIII programs. I want to highlight a few specific promising programs and strategies that address the nursing shortage and the faculty shortage. First, at our foundation, we fund scholarships to support accelerated nursing degrees for students who already have a degree in a discipline other than nursing. These are typically students that are ineligible for federal aid programs, and I can tell you these scholarship programs are hugely oversubscribed. Second, we are providing career development awards to outstanding junior faculty. Third, there are many state partnerships of nurses, educators, consumers, business groups, government, and philanthropy that are working together on practical creative solutions like using shared curriculum, online education, simulation centers for training, easing the transition from associate to baccalaureate programs, and increasing the diversity of the nursing workforce. Taken together, these programs seek to increase the number of baccalaureate-prepared nurses, provide incentives and rewards for nursing faculty to educate the next generation of nurses, shorten the pipeline for providing new nursing faculty, and provide a new cadre of nursing leaders. Now, as we consider the critical task of ensuring that the education system can graduate new nurses, we must also retain experienced nurses. We have a demonstration project called Transforming Care at the Bedside that shows that hospitals can successfully retain nurses through organizational reforms that do not add costs. I know that my colleague, Dr. Mullen, will focus on the shortage of primary care physicians, but nurse practitioners are an effective, high-quality way to fill the gap in primary care, particularly as we think about access in rural and other underserved settings. So in conclusion, as Congress addresses both the shortage of primary care physicians and the need to control spending, I encourage you to think about opportunities to use nurse practitioners more widely and effectively. Thank you for this opportunity to testify today and for your attention to these issues that reach beyond ensuring health care coverage and allow us to strive for comprehensive, meaningful reform.
Thank you, Doctor. Dr. Mullen?
Chairman Pallone and Ranking Member Deal, members of the committee, colleagues, thank you for the opportunity to testify today. I will be talking about the workforce, the clinical workforce, largely physicians, but not, I emphasize, limited to physicians. I started as a physician in the National Health Service Corps. I served for a period as the director of the National Health Service Corps, and in recent years I have worked in scholarly pursuits trying to understand the dynamics and policies related to the health workforce. So I've practiced it, I've run it, and now I'm studying it, and I'm here to share that with you as much as I can and very expeditiously. Massachusetts has been cited as an example, and I will say to you it is an example of my principal premise to you,
and that is that substantial reform and improvement in access and in health care in this country will not take place without substantial reform and improvement in the health workforce in this country. And the experience of Massachusetts has been when you provided expanded access, they did indeed come, and where they hit the first bump in the road was the absence of a good, strong primary care base, even in a state that's well endowed with physicians. So primary care is at the core of reform of the health workforce. A few words about the shape and size of the health workforce. I offer you this graphic as a way to conceptualize what I consider the three phases of the life cycle of a physician, and that would be medical school, graduate medical education, and practice. Clearly, practice is a 30 to 40-year proposition. The others presumably are somewhat shorter, but all three have a character and a legislative component, and I suggest you consider those in that regard, and we'll go through them in a moment with the particular legislative potentials of each of those. In general, we do have problems in primary care. We have a smaller base compared to many other countries in terms of how we approach it. We have really an inverted pyramid with a small base and a large wobbly superstructure of people engaging in specialty and subspecialty clinical roles. More important than this are the trends in primary care, which for a variety of reasons ranging from reimbursement to what's in, folks are not going into primary care. That is a huge problem for the future, and one that can be addressed both by investments financially, but also by statements by public bodies such as the Congress that this is important. Overall, my judgment would be in the somewhat contentious area of do we have enough doctors. I think we are in the right zone. We have a 30-year history now of increasing physician-to-population ratio. We're at about 280 per 100,000. That puts us a little bit ahead of Canada and the United Kingdom, a little bit behind Germany and France. All these countries, including ourselves, are going to experience problems of aging population, and I'll address those in a moment. Our major problem, however, is they're poorly distributed. Physicians tend to be urban, they tend to be in well-to-do areas, and they tend not to go where the most severe problems are. That has been and has continued to be a problem as we produce more doctors. They tend to continue to locate in similar areas. So we could make far better and more prudent use of our workforce if it was better distributed both in terms of geography and specialty. And we have two American inventions that are enormous assets in both what is happening now and what should and can happen in the future. And those, as referenced by Dr. Loviso Mori and others, are physician assistants and nurse practitioners. About 70,000 of the former, 100,000 of the latter. We invented them. Now the rest of the world is running to try to catch up, but they have shown very effective use, and they are effective not only in the primary care area, but in the specialty area. A way to attenuate our need for more specialists is more collaborative work with non-physician clinicians, including particularly nurse practitioners and physician assistants. We also have in place two very important programs that affect the workforce, and that's the National Health Service Corps as an incentive program and community health centers as a deployment mechanism to put folks to work. Those need to be invested in and continue to be recapitalized. Now let's quickly go through this continuum. In medical school, we are seeing expansion. New medical schools are coming online. Old schools are expanding their capacity. This is good. We have, in addition, two very important programs that impact medical education. The first is Title VII in the jurisdiction of this committee. It's an old program. It could use reconceptualizing and certainly reinvigorating, but it is where the federal government offers or can offer incentives to medical schools and medical students for different kinds of careers, and there's a lot that could be said about that important area of investment. And of course the National Health Service Corps, which happily is receiving more attention. There are about 3,500 people in the service, in the field today. About half of those are physicians. You're talking 1,700 physicians, 800,000 physicians in America. This is a very, very small, important, but small program. It needs to get onto the map in a more major way. Graduate medical education, a very important area, not primarily the jurisdiction of this committee, because it is $8 billion, $8.5 billion in Medicare funds that fund GME largely. It is a huge program without, as I've characterized it, a brain. It's formulaic. It is not currently available to help with workforce redistribution. A great deal could be done with that. A great deal of attention needs to be paid to that. Modest activities would include incentivizing community-based and ambulatory training. More major would be realigning Medicare GME with national workforce needs with a better and more formal allocation system. And finally, in practice, a lot to be done. If you train them and put them out in an environment that devalues primary care, they will find other ways to do other things and charge the system in other ways. So practice has to be realigned. We need payment reform. We need practice organization reform, primary care medical homes, accountable care organizations, and finally health information systems, which happily are getting attention, will make the primary care provider, all providers, but particularly primary care that's information rich, much more effective. Finally, two ideas that I think need attention. One is we function in an information poor environment in terms of workforce planning. Data is not good. We need a National Center for Health Workforce Studies that would, on a regular basis, work on census issues, on analytic issues, and on projection issues. And finally, a National Health Workforce Commission, a deliberative body, perhaps on the order of MedPAC, that advises the Congress, the administration, and the American people on issues of workforce. A very important, a very difficult, complex area. We need brains at work on that day in, day out with the sanction of the Congress that would help us think through these dilemmas. So I thank you for your time. I'll be happy to engage in discussion and participate with the committee as you consider reform in this area. Thank you, Mr. Chairman.
Thank you, Dr. Mullen. Dr. Harris.
Thank you, Chairman Pallone and Ranking Member Deal, for allowing me to share the American College of Physicians' views on primary care workforce and how it affects access. I'm Jeff Harris, President of the ACP. Until recently, I practiced in a rural community with a population of 40,000 in Virginia. The office in which I practiced focused on the delivery of primary care and nephrology. This year, I've had the good fortune to be president of the American College of Physicians, representing 126,000 internal medicine physicians and medical students. The United States is experiencing a primary care shortage in this country, the likes of which we have not seen. The demand for primary care in the U.S. will grow exponentially as the nation's supply of primary care dwindles. The reasons behind this decline in the supply of primary care physicians are multifaceted and complex, but they include the rapid rise in medical education debt, a decrease in income potential for primary care physicians, failed payment policies, and increased burdens associated with the practice of primary care. Many regions of the country already are experiencing primary care shortages. The Institute of Medicine reports that it would take about 16,000 additional primary care physicians to meet the needs in currently underserved areas. Two recent studies found that the shortage of primary care physicians for adults will grow to over 40,000, even after taking into account the important contributions of nurses, nurse practitioners, and physician assistants as part of the primary care team. Approximately 21% of physicians who were board certified in the 1990s have left internal medicine, compared to 5% who have departed from internal medicine subspecialties. Equally alarming is the fact that the pipeline of incoming primary care physicians is also drying up. In 2007, only 23% of third-year internal medicine residents intended to pursue careers in general internal medicine. This was down from 54% in 1998. Even more troubling, a recent survey found that only 2% of medical students plan to go into general internal medicine. ACP strongly supports the need to ensure all Americans have access to affordable health coverage. As more people are covered, though, the primary care workforce needs to grow to take on more patients. Primary care physicians are the first line of contact for individuals newly entering the healthcare system. If we do not increase the primary care workforce, it will become impossible in many communities for people who do not currently have a relationship with a primary care physician to find an internist, family physician, or pediatrician who is taking new patients. In Massachusetts, where health insurance coverage was recently expanded, and nearly 95% of the state's residents have coverage, The wait to see primary care physicians in Massachusetts has reportedly grown to as long as 100 days. Yet Massachusetts has a higher physician-to-patient ratio than most other states. The cost of providing coverage to more than 46 million uninsured Americans will be much higher, and the outcomes of care much poorer without more primary care physicians. More than 100 studies referenced in the ACP's recent paper, How is a Shortage of Primary Care Physicians Affecting the Quality and Cost of Medical Care, demonstrates that primary care is consistently associated with better outcomes and a lower cost of care. For instance, one study found that an increase of just one primary care physician per 10,000 population in a state was associated with a rise in the state's quality rank and a reduction in overall spending by $684 per Medicare beneficiary. The United States needs a comprehensive approach to ensure access to primary care. We should start with a national health care workforce policy process to set specific goals for educating and training a supply of health professionals, including primary care, to meet the nation's health care needs. In the United States, the numbers and types of health care professionals being trained are largely determined by the availability of training programs, the number of applicants, and inpatient service needs of academic medical centers. But institutional service needs are poor indicators of national health workforce requirements, particularly as patient care has continued to shift from inpatient to outpatient settings. The Institute of Medicine has recommended, quote, a comprehensive national strategy to assess and address current and projected gaps in the number, professional mix, geographical distribution, and diversity, end quote, of the healthcare workforce. Secondly, we need to fund programs to cover the cost of medical education for students who agree to pursue careers in primary care and subsequently practice in areas of the nation with greatest needs. Third, Medicare payment policies need to be reformed. The career choices of medical students and young physicians should be largely unaffected by considerations of differences in earnings expectations. Yet Medicare payment policies systematically undervalue the comprehensive, longitudinal, preventive, and coordinated care that is the hallmark of primary care. Currently, the average primary care physician earns approximately 55% of the average earnings for all other non-primary care physician specialties. Studies show that this compensation gap is among the most significant reasons for the growing shortage of primary care physicians. To eliminate this differential as a critical factor in medical student and resident choice of specialty, the average net compensation for primary care physicians would need to be raised by Medicare and other payers to be competitive with other specialties. We recommend that Congress institute a process that would result in such targeted annual increases in Medicare fee schedule payments to make primary care competitive with other specialties over a 5-year period beginning next year. The funding for such payments should take into account primary care's contribution to reducing overall Medicare cost associated with preventable hospital, emergency room, and intensive care visits, many of which are reimbursed under Medicare Part A. Although it may appear to some that our call to increase Medicare payments to primary care is self-serving, the fact is that almost half of the ACP's membership practices in subspecialties, not general internal medicine. Yet they share our belief that having a sufficient primary care workforce is essential if patients are to have access to high quality, effective, and affordable care. Finally, we need new payment models that align incentives for accountable, coordinated, patient-centered care, included continued expansion of the patient-centered medical home. The Commonwealth Funds Commission on High-Performing Healthcare Systems recently issued a report.
Dr. Harris, I know I didn't stop you because I was interested, but you're 3 minutes over, so got to wrap up.
I apologize.
That's
for
all
being
right.
so- One last paragraph. In conclusion, the United States faces a critical shortage of primary care physicians for adults. We believe that it is imperative for all Americans to be provided with access to affordable coverage. We also know that coverage alone will not ensure that patients have access to high-quality and affordable care if there are not primary care physicians available to meet those needs. Thank you for your patience.
Thank you. Dr. Bean?
Thank you, Chairman Pallone and the Ranking Member Deal and members of the Health Subcommittee for the opportunity to address you about patient access to medical care. My name is Jim Bean. I practice neurosurgery in Lexington, Kentucky for the past 29 years. I serve currently as president of the American Association of Neurological Surgeons, and this is a member organization of Doctors for Medical Liability Reform, the Health Coalition on Liability and Access, and the Alliance of Specialty Medicine. Access to effective medical care depends on a number of factors, and we've talked about them, but one that's too often neglected is a barrier to access that's created by a malfunctioning medical liability system. I think it's safe to say there's near universal agreement among physicians, patients, and policymakers that our medical liability system is broken. Defining how is the issue. In 2005, Senator Hillary Clinton and Barack Obama acknowledged this when they co-sponsored medical liability legislation to deal with the mounting access to care crisis. 2008 white paper, Call to Action, released by Senate Finance Committee Chair Max Baucus, also acknowledges that the current legal environment leads to the practice of defensive medicine and calls for alternatives to civil litigation so that the administrative costs associated with litigation, which account for 60% of malpractice premiums, can be reduced. Those at the forefront of healthcare reform understand that it will do little good to achieve universal insurance coverage if the doctors who actually supply critical aspects of care are either driven from practice or retire early or simply shun the life-saving procedures that need to be done because of uncontrolled risk. The problem of access to care is especially critical for high-risk specialties. We've been talking a lot about primary care, but we should not forget that specialty care has to be rendered in a safe system. Specialties such as neurosurgery, obstetrics, orthopedics, general surgery, emergency medicine, and others. These specialties have been hit particularly hard by lawsuits and rising insurance premiums, and they're the same ones who provide critical emergency services. And when they leave enormous gaps. The crisis persists despite a clear record of successful reform in some states. Mississippi and West Virginia both faced critical loss of medical services because of a doctor exodus because of skyrocketing liability costs. Mississippi lost a substantial number of obstetricians. Both states, West Virginia and Mississippi, lost enough neurosurgeons to endanger their emergency care system. Liability state reforms dramatically reversed the trend, and doctors have begun to return. All states should have the same advantage. Perhaps the most dramatic is Texas. We've heard about it before reform in 2003. Doctors fled the state. Texas ranked 48th out of 50 states in physician manpower, and since medical liability reform, 69 underserved counties have seen a net gain in emergency physicians and a number of other specialists. Access to care was clearly improved. While we strongly believe that comprehensive reforms passed in Texas should be applied nationwide, other proposed reforms may help as well. They include early offers, specialized health courts, and a presumptive defense by using evidence-based medicine. The President endorsed such an approach in a New England Journal of Medicine article printed online. It's entitled Modern Healthcare for All Americans, and it was published during the presidential campaign on September 24th, 2008. I have a copy if you'd like. He wrote that he would be open to additional measures to curb malpractice suits and reduce the cost of malpractice insurance. And he further wrote, I will also support legislation dictating that if you practice care in line with your medical society's recommendations, you cannot be sued. We strongly support the President's announced position and look forward to its implementation as policy. Our President and this Congress are dedicated to reforming our healthcare system and ensuring access to care. But access to quality care must come first, and ensuring patient access to care means acting now to fix a critically ill medical liability system. Mr. Chairman, thank you.
Thank you, Dr. Bean. Dr. Rowland?
Thank you, Chairman Pallone and Ranking Member Deal and members of the committee for the opportunity today to participate in this hearing on making health care work for American families. My testimony today will address the role public programs have played in improving access and helping to reduce health care disparities. Indeed, health care coverage matters. It may not be enough to assure access, but without it, access to care suffers and disparities rise. Together today, Medicare and Medicaid provide coverage to over a quarter of our population, 80 million Americans, our oldest, our poorest, our most disabled, and among our sickest residents. Both programs for over 40 years have been central to our nation's efforts to improve access to care and the health care of the American people. Medicare has helped to provide access to care for the elderly by easing the financial burden for care and opening up access to the broad range of medical services and new technology that has helped to both extend life and promote better care. Medicare has helped not only to improve access to medical care, but also to reduce racial barriers to care, both through the enforcement of the civil rights legislation that led to the desegregation of health facilities and by providing equal benefits to all beneficiaries without regard to health status, income, racial or ethnic identity, or state of residence. Medicaid is the workhorse today of the U.S. healthcare system, providing coverage for almost 60 million Americans left out of private health insurance and with very special health care needs. Medicaid coverage of the low-income population provides access to a comprehensive scope of benefits with limited cost sharing that is geared to meet the health needs and limited financial resources of Medicaid's beneficiaries, who tend to be both sicker and poorer than the privately insured low-income population. And Medicaid also helps to address racial and ethnic disparities in access to care. Because minority Americans are more likely than whites to be low-income and without access to job-based coverage, Medicaid provides an important safety net, today covering 1 in 4 non-elderly African Americans and Latinos. In fact, minority populations compose over half of the Medicaid beneficiaries. The comprehensive scope of Medicaid benefits is critical given the low incomes and complex health needs of the population Medicaid serves, including the chronically ill and people with severe disabilities. When the health needs of the beneficiaries on Medicaid are taken into account, Medicaid is in fact a low-cost program. Both adult and child per capita spending are lower in Medicaid than under private health insurance. Medicaid enrollees, however, tend to fare as well as the privately insured on important measures of access to primary care. Uninsured children have significantly higher rates of no usual source of care compared to only 4% of publicly insured children and 3% of privately insured children. 1/3 of uninsured children have no usual source of care. There have been great gains in reducing the share of low-income children who are uninsured through the expansion of Medicaid and CHIP, demonstrating that public programs can provide a solid platform from which to expand coverage. As the nation moves forward to consideration of how to provide coverage to the over 45 million uninsured Americans today, Medicaid's role for the low-income population provides a strong platform on which reform efforts can be built, as evidenced by the recent experience with children's coverage. One must recall that the uninsured population is predominantly low income, 2/3 with incomes below 200% of poverty, or roughly $44,000 for a family of 4 a year. Medicaid provides a strong and tested foundation upon which to build these health reform efforts, but it could play indeed a stronger role if coverage of the low-income population was improved through expanded eligibility and reduction of enrollment barriers, through addressing payment rates and administrative burden to help boost provider participation and promote greater access to primary care especially, and through a stabilization of financing so that the periodic cuts in the program that affect reimbursement to providers and coverage for beneficiaries do not need to occur. In summary, the Medicaid program has an established track record in providing the scope of benefits and range of services to meet the needs of low-income population, including those with chronic illness and severely disabling conditions. Drawing on Medicaid's experience and already substantial coverage of the low-income population offers an appropriate starting point for extending coverage to the low-income uninsured population through health care reform. While health insurance coverage is essential to open the door to the healthcare system for these individuals, broader measures, as you've heard discussed today, need to also be put in place as a complement to assure that the coverage card is not an empty promise. Thank you.
Thank you, Dr. Rowland, and thank all of you. I know it's a large panel, but you covered a lot of very important areas, and we appreciate it. We now have questions from the members, and I'll start with myself for 5 minutes, and I'm going to start with Dr. Mullen, and I'm going to throw a few things at you here. I don't know if you even will have time to answer them all, but I'm very concerned about the financing of medical education. You know, the whole idea of Medicare financing GMEs. You know, if you were to suggest to me that we probably should have an alternative financing mechanism, and I maybe even use Medicare, I'd like to hear that. But even more important, my concern is about, you said 30% of the doctors are educated abroad. To me, that makes no sense, and I don't think any effort's being made to reverse that. If anything, it seems to me that we'll probably see a situation where more of our physicians are educated abroad, and that makes, you know, no sense to me. I talk about how I attend events in my district with medical doctors who are raising money for Caribbean medical schools rather than for UMDNJ, you know, in New Jersey. There were reports in the media a few months ago about foreign medical schools raising money and buying essentially residencies at hospitals in the New York metropolitan area so that their students would have preference for residencies over graduates of American medical schools. What does this all mean in terms of the quality of physicians that so many are educated abroad, be they Americans that go abroad or immigrants? What is it? I mean, where are we going? Does, you know, some of these schools, they seem to be opening more and more overseas. A lot of them are private, not even, you know, government run. I don't know what kind of controls they are. Should we reverse this? You know, I'm not even talking about the impact on other countries, you know, potential brain drain on other countries. I mean, that concerns me less. Maybe I should be concerned about it, but I'm not so much. Would you address that? Because I hear about it every day at home. I know it's a lot to ask you, but...
Well, I'll try to give the 2-minute synopsis on international medical graduates and how we've gotten to where we've gotten and what we can do about it. Very quickly, we have chronically undertrained. We've not trained sufficient physicians in our medical schools. And over the years, we put a lot of investment from the Congress in particular and from state governments into medical education at the medical school level in the 1960s and 70s. And this had a very good response. We doubled the output of medical schools between 1965 and 1980. At that point, everybody said, whoa, we're going to overshoot, and funding was throttled back. Schools remained where they were. So between 1980 and 2005, we lost one medical school, net loss of one. And the graduating class, 16,000, 16,500, every year was the same. Meanwhile, over time, the residency opportunities grew, reflecting somewhat the needs in the country, and the opportunity for international graduates who took exams like the U.S. exams. Today they take exams that are exactly the same, to come and fill residency positions and then remain in practice grew. So that today about 27% of our residents and 25% of our doctors in practice are graduates of international schools. A minority of these, about 20% today, come from schools in the Caribbean, which are essentially designed for U.S. students to go abroad and come back as U.S. international medical graduates. That's because the need for medical education was not being met onshore. We didn't have enough placements.
But doctor, should we be reversing this? I mean, my fear is the quality is good? I mean, is this the way for us to save money? So we should say, great, let's have everybody educated abroad because it costs us less, and let that burden, be passed on to someone else. Doesn't matter. And are we doing anything to change it?
The answer is yes, we should be reversing it. That is good domestic policy. It's good foreign policy, both. It gives more opportunity to domestic students if we have opportunities for them to train onshore, and it diminishes the brain drain, which is bad foreign policy around the world. Many governments are resenting the fact that we're pulling their doctors here. The way it is happening, and it's happening in a somewhat spontaneous fashion, is that medical schools are now growing again, increasing the opportunities. It's estimated that the medical school positions over the next 3 or 4 years will grow by 25%. And what will happen by all estimates is that as more U.S. graduates come out, they will be selected for residency positions, and de facto or in passing, the international medical graduates will have less opportunities. There will be less drawn from abroad. The problem—
But is that true? I mean, if they, was this an aberration that I read in the New York Times where these foreign medical schools are now essentially buying residencies?
The foreign medical schools you refer to are the Caribbean commercial schools that are training largely U.S. students abroad. And they did conclude, one of them concluded a large agreement with the New York Health and Hospitals Corporation for medical student places on their wards. It's unclear what will happen, but U.S. New York-based schools that have placed their students there are in competition for those. Traditionally, they have not paid for them. And it'll be interesting to see how that plays out. But I think the point is, if the opportunities for practice in the U.S. For international medical graduates diminish because more and more of our positions are being filled by our own graduates, that business will diminish. And we will not be so reliant on foreign graduates, whether they're U.S. to begin with, U.S. citizens to begin with, or international citizens.
So you think we're reversing this policy and we shouldn't worry much about it?
I think we should remain concerned about it. I think we're in a period where it is going to diminish. Now, we should understand that the number of residency positions in the country has remained relatively fixed. In round numbers, about 100,000 people are in residency every year, about 25,000 new people enter residency each year. If we increase GME funding, graduate medical education, Medicare funding, we will increase the opportunities, and that will again begin to draw on the rest of the world. So right now, where the positions are capped under Medicare, that is, Medicare reimbursement is capped, we're not creating more residency positions. So the increased number of U.S. medical school graduates will go into a fixed number of positions, and by doing that, it will diminish the number of international graduates that we bring into our country.
Thank you. Mr. Deal?
Thank you. I'd like to follow up on that, too. I had a constituent, I asked him what his doctor told him. He said, I don't know. I didn't understand a word he said. And that's a continuing problem. I didn't realize the percentages were as great until I read your testimony. With regard to the New York situation that you talked about, if we are funding graduate medical education through Medicare, and the hospitals are now entering into private negotiated purchases of those slots, are we in effect funding slots through public funding that are now being in effect sold to foreign medical colleges?
That's a good question. I think the answer is no, because as I understand the agreement in New York, it is for the training of medical students, not for graduate medical education. The residency slots, which Medicare funds, remain the same. They are filled by both U.S. graduates and international medical graduates. Remember, I said we graduated about 16,000. If you add in osteopathic medical schools, U.S.-based, we graduate about 18,000 every year. We offer 24,000 internship positions, postgraduate year one. So the difference between the 18,000 we graduate and the 24,000 that are offered are filled by international graduates, U.S. international graduates and non-U.S. international graduates. As the U.S. graduate numbers rise, with the 24,000 positions to be filled, the international medical graduate numbers will diminish.
Let me go to Dr. Harris, because on a related subject to those residency slots, you make the point that we don't have enough we do not have enough residents in their postgraduate education going into primary care to the primary care internal medicine slots. How do we correct that? Is that something that should be, the funding should be channeled more in the direction of those residency slots rather than the others, or how will you suggest we fix that?
Well, we do recommend that there be focused GME funding on expanding the number of primary care spots. We feel that you need to be attentive to that. But the answer comes when you interview young people and ask them, why are you not choosing primary care for a career? And the answers are three. One, it gets back to the question about medical education. You can argue that fundamentally there's a design flaw with medical education in that most medical schools in this country are centered around tertiary care centers, where the most ill people in the states are sent for their care, or the most exotic illnesses are sent for very focused care. It is intellectually wonderfully satisfying. It's a wonderful place to spend 4 years. But there is precious little exposure to what the majority of health care is in this country, namely outpatient, ambulatory care. So one of the things you do is need to increase that exposure to show young people that following patients longitudinally, knowing them for years if not decades, is a pleasure. The second thing has to do with the pace, and that gets back to the notion of this medical-centered home or funding for bundled care that allows the expansion of the team, that gives physicians time with their patients. Remember, 20% of the Medicare population in this country has 5 or more chronic illnesses.
Okay, let me stop because my time's running out.
Yeah.
I understand that. I think your point is well made that that the traditional residency is in a hospital environment, whereas the primary care physicians that we need to be attracting, their practice is not going to be necessarily in that hospital environment. We need to have a different environment in which for them to complete that exposure. Is that what you're saying?
We need to increase their exposure to ambulatory medicine during their training.
But doesn't that have to be done under the auspices of a hospital that is providing the residency program?
Yes.
Okay. All right. Let me go back to Dr. Mullen just a second. We know that NIH funding has been significantly boosted as a result of the stimulus input. You made a statement in your written testimony talking about the rise in NIH funding from $2.4 billion in 1970 to $16.3 billion in 2004. And you said creating a robust culture of research at medical schools that dominates medical school finances, faculty values, and school culture. Now, with this huge influx of new money into NIH, is that going to exacerbate this problem about the focus of medical schools and focus it away from increasing primary care training, or is it going to help it? Which way is it, or neither?
A good question. The stimulus money is focused in very practical ways, and I think would probably be more practice-friendly perhaps than traditional NIH funding. But the point is well taken and I'm not here to talk against NIH funding. I am here to talk for balance. And we need to think if our medical schools are being endowed with enormous research money, creating a culture that values research and specialism when the problems in the country are generalism, we need to think about how to rebalance that. And medical schools and funding for generalist research is important as well.
Ms. Christensen.
Thank you, Mr. Chairman. I didn't expect you to come to me that quickly. Thank all of the panelists, as I said, for not only your testimony today, but for the work that you've been doing over the years. Dr. Smedley, and I'd probably ask Dr. Rowland to also answer, I'm an advocate of building on the public programs to expand coverage, but I have a concern that as we reform the system, that we don't perpetuate a two-tiered system of care. There have been several studies that I've seen that have shown that despite the increased access that Medicaid patients have to services, they don't have as good outcomes. have about the same outcomes as the uninsured. So why do you think this is, and how can we fix the problem? And is there a role for the public plan that we're talking about in all of this? Dr. Smedley?
Sure. First, I agree with Dr. Rowland's statement that Medicaid has been vitally important for low-income communities and communities of color. I have no doubt that without Medicaid, many more people would have suffered unnecessarily, and we would have had many more premature deaths. By the same token, though, we know that there's some things that need to be fixed. And so it's important that we try to address the fact that we have tiered health care insurance systems. And so to the extent that people of color are disproportionately in lower tier systems, this in itself can be one of the many causes of health care inequality. And it's important that we take steps to strengthen Medicaid so that it's not stigmatizing to be a Medicaid patient. I was sharing with you earlier a story. I was surprised to walk into a county health clinic in one of our northeastern states. I walked into a waiting room that was approximately 20 feet by 30 feet, a very small waiting room where you could hear your name if you were called, but yet along one of the walls there was a sign that said Medicaid patients only. This was surprising to me because it further stigmatizes Medicaid patients. And so to the extent that Congress can take steps to ensure that all of our public plans are comparable to private plans in terms of coverage, quality incentives, and performance incentives, I think this will go a long way toward reducing that inequality.
Well, Dr. Rowland, we want to make sure that the card isn't an empty promise too. And it just seems to me that when you have a Medicaid card and another card, you know, it just opens the door for bias.
I think there are two things to note here. One is that many of our low-income populations live in medically underserved areas. So much of the discussion we've had today about bringing more resources into that area is important. I think the second thing to note, however, is that we can do more to make Medicaid payment rates more equalized with the rest of the healthcare system, and that unfortunately, as we gave states greater flexibility over their programs, many of them have used that flexibility when they need to cut costs to reduce payment rates, although we do see states improve those payment rates whenever their resources are more abundant. So over the last few years before this economic downturn, many states moved to up their payment rates. I think that the most important thing is to make sure that the card provides people with access to physician services and to primary care services. And I think we should note that within the Medicaid program over the last few years, the advance of managed care and the use of primary care networks has helped to really secure a better access, though I do worry that in some cases the providers willing to participate in those networks are not the same as the providers willing to provide care to the privately insured.
Thank you. Dr. Labizan Moray, thank you for the work that Robert Wood Johnson has done, and I was really interested in the Family Nurse Partnership Program as well as the others. But we hear an argument, and we asked the CBO director, several of us did, over and over again about savings that would be realized by prevention, and you talk about a saving that you see in the Family Nurse Partnership Program. Their argument is that we'll just spend more money on prevention, and so we won't realize any savings. And I find this a major obstacle to getting done what we need to get done and making the investment. How would you respond to that?
Thank you for this question. When people talk about prevention, they often lump a number of issues together that really should be separated. First, you referenced the Nurse Family Partnership Program. That is a program, for those who don't know, that invests in the relationship between nurses and moms-to-be or young mothers, that teaches them how to navigate the healthcare system, but also how to provide better health for themselves and their babies. So it's an investment in health that happens in the community. The benefits that accrue from that investment happen over a number of years, not 2 or 3, but really over 10 to 15 years. We continue to see savings up until the child is in their adolescence. So one has to look for the savings over a long enough period of time, first of all, in order to really understand whether there are savings. Secondly, we often talk about prevention, and we're really referring to clinical services, screening tests and the like. And there, frankly, the results are mixed on whether it's going to provide savings. However, we do know it almost always improves health and produces a better value. But one has to also separate from that prevention that occurs at the community level, community-based investments such as reducing obesity, improving physical activity, reduction of tobacco use. These have been shown time and time again in large public health studies to reduce the overall costs of care because they improve the health. And we really need to focus those three separately if we're going to answer the question of whether prevention saves money.
The gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. I'm going to try to be quick. It's a huge panel. Appreciate you all coming, and I'm apologizing for being in and out like we all have to do in this business. Let me ask a question, and if you can answer briefly, and I try to get the whole panel. It depends on how quick you answer. You know, Senator Baucus on the other side's basic premise is Medicaid for all, cover the uninsured. Would you support that, Dr. Smedley? I mean, we're hearing some bad comments on Medicaid here.
I believe it was Medicare for all, if I'm not mistaken, which...
okay, well, let's assume that we want to cover the uninsured through Medicaid. Would you support that?
It's important that we ensure that everyone has comprehensive care and that...
So would you support the current state-run Medicaid system ensuring the uninsured today?
I'd support as broad a pool as possible.
So would you support Medicaid, state Medicaid programs covering the uninsured of each state?
That is an option that can work in many states. I'm sorry, I can't give you a definitive answer on that.
Okay. Dr. Kitchell?
Yes, I think that Medicaid should be expanded, but I also think that we should maintain private insurance for patients who need it.
Okay. Even with, okay, thank you. That's good. I really want to go quick, and I don't want to be disrespectful. Dr. Satoris?
I'm going to second Dr. Smedley. In some states it'll work, in others it may not.
Okay.
Not answering your question, I understand that.
All right. It's good to know when you don't are on the record, because that makes a statement about the current Medicaid system. Ma'am, I don't even want to butcher your name. I'm sorry.
Lovizo Mori. It's a mouthful, I know. Our foundation does not advocate for specific plans, but we do have principles that suggest that there are a broad array of ways to, as Dr. Smedley says, ensure that we can increase the number.
Okay, but my focus is on Medicaid system in states as we know today. Would covering the uninsured through Medicaid system in states, is that a way to ensure the uninsured?
It is one way among others.
So you're not going to answer either? Sir? I don't see your name tag. I apologize.
I would agree it is one of a number of options. It would not be my preferred option.
Great. Dr. Harris?
Congressman, in our paper, we felt that
Quicker, please.
consideration should be given up to 200% of the federal poverty limit for covering people. That would capture a sizable number of these people.
So you're saying yes?
Yes.
For 200% of poverty?
As part of this overall pool of people, that will in no way capture all of the unemployed.
Dr. Bean?
Uninsured.
No. The benefits are wide, but the pay is so low you won't get participation.
Dr. Rowland?
For the low-income population, 2/3 of the uninsured, expanding Medicaid would make a lot of sense.
How about for the uninsured?
Yes.
Okay. Let me go with this question. It's stealing Dr. Burgess's. Would you trade your current insurance policy for a Medicaid policy? Dr. Smedley?
No.
Just go down the table. Dr. Mitchell?
Yeah, as I said, some private insurance, and I was paying...
Yeah, would you trade yours for a Medicaid policy?
No.
No.
My plan has things that Medicaid does not have in it.
So that's a no?
That's a no.
Thank you.
No.
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 Yes.
You... Thank you. We may give you that opportunity to do that.
Medicaid has low-cost sharing and comprehensive benefits and covers a lot of services that private insurance doesn't.
Obviously, with the doctor's question about, or your question about someone going into a clinic being casted as Medicaid only, this line versus other lines, that's why I asked that question. It's really a follow-up. I'm really involved. This is my district I have about 14 community health clinics. They service, Illinois service 1.3 million Medicaid, uninsured, Medicare, and for-pay folks. It's been very successful. When I first got elected to Congress, I had 0 in my district. Now, the benefits of community health clinics are what? The people who practice there are protected by the Federal Tort Claims Act. It has allowed them to provide health care to the insured. Do you think that some model, talking about what happened with Texas, what happened in Illinois, although our legislation is being reviewed by the Supreme Court, we had medical liability reform for my neurologist. There was a time when we did not have a single neurologist south of Springfield because of medical liability. Would moving on a Federal Tort Claims Act provision on medical liability be helpful in access to care and keeping costs down? And I'd go to the final panel, Mr. Chairman, and I'll be done with that. Dr. Smedley.
I don't know if the evidence speaks to that. Community health centers are successful not solely because of tort issues, but because of...
So you're saying that the fact that they don't have liability costs because they're protected, that doesn't affect the way they charge individuals?
No, community health centers have done a marvelous job targeting the needs of low-income and underserved communities. I believe that's the primary reason that they're successful.
I would beg to differ. Dr. Kitchell.
Yes, I think community health centers are a good idea. We've actually applied.
I'm talking about the Federal Tort Claims Act protection on community health centers.
That would help, yes.
Yes.
Practice in a community health center, I have to agree with Dr. Smedley. The reasons that they are successful have much more to do with other issues.
Do you pay any liability insurance when you practice in the community health center?
No, I do not.
Okay, thank you.
Health centers are distinctly successful for other causes. Is the tort protection afforded to providers there useful? Yes.
Dr. Harris?
Simply agree with Dr. Mullen.
Yes, it would help.
I agree with Dr. Mullen.
Okay. Thank you, Mr. Chairman. I think tort issues should be part of this healthcare debate. I yield back.
Thank you. Mr. Braley.
Dr. Kitchell, I want to follow up on some of the points you raised in your opening statement, especially dealing with geographic reimbursement inequities. You mentioned the Geographic Practice Cost Index, is also commonly referred to as GPCIs, reduce fees for physicians because of where they live. In your best estimate, what is the differential in Medicare fees between the highest GPCI areas and the lowest GPCI areas?
The differential is 34% between North Dakota, Arkansas, and then the highest areas in California.
And then to follow up on your point, when you're out looking to replace equipment and looking for durable medical goods that you use in your practice, have you found a similar inequity in terms of what the cost of those of that equipment is based upon geographic differences?
No, in fact, about 2 years ago when we decided to buy an electronic medical record, that cost of $21 million for our clinic is exactly the same as anywhere in the country.
Can you explain in further detail how it is that these reimbursement inequities built upon a flawed GPCI formula impact access to care in rural areas?
Well, there are some services that are not even paid as much as the cost of delivering those services. Let me give you an example of a cardiac defibrillator implant. The Medicare reimbursement for that is actually less than the cost of the device. So the payment for the labor, the payment for the rent, the payment for all the other services that patient needs, Medicare pays less than the cost of that machine.
Now, one of the solutions that's been proposed is putting a floor on GPCI inequities, and we know that by enacting a 1.0 floor on work GPCIs, we reduce the inequities, even though there's still this 8% differential you mentioned in your testimony. Do you feel that a 1.0 floor on practice expense GPCIs would also decrease rural healthcare disparities?
Yes, that would be our best solution.
Earlier this year, I spoke in this committee about the need for a reimbursement system that rewards quality. Can you explain how a model system might look to provide quality-based reimbursements to physicians?
Yes, as I said, the PQRI program is flawed. The hospital system is doing a good job of rewarding quality. Quality needs to be rewarded for teams, groups, and systems. Quality is team-based care. The medical home model, the bundled systems, the shared savings, they rely upon physicians working together with non-physicians in teams. So we should be encouraging, we should be incenting physicians to be part of teams, groups, and systems. And as I mentioned, the Middlesex, Connecticut example is a great example where independent physician practices have gotten together in an accountable care organization, and they have increased their quality and reduced the costs of care. I think this is a key point for Americans, is to understand that by working together, physicians and non-physicians working together, we can improve quality and we can reduce costs.
All right. Dr. Bean, I want to follow up a little bit on your testimony, because one thing that was noticeably absent from your testimony was a discussion of preventable medical errors. And there's been a lot of testimony from the panel about the importance of an Institute of Medicine finding relating to access to health care, but no one has mentioned the seminal Institute of Medicine study in 2000 and the follow-up study identifying the acute problem of preventable medical errors and the cost they impose on the system. So do you agree that the most effective way to reduce malpractice costs in this country is by reducing or eliminating preventable medical errors?
I'm afraid I don't agree that's going to eliminate the malpractice crisis in the areas where malpractice is used or abused. Well, I think that I will agree with you that the focus on preventing medical errors is not only laudable, but highly necessary.
Well, can you explain why the existing framework for health quality oversight that is in place in this country, primarily through the Joint Commission on Accreditation of Healthcare Organizations that is hospital-specific, has failed to make a measurable decrease in preventable medical errors, despite the fact that their Sentinel Event Program has been in place for over a decade. And if you take the IOM numbers of 44 to 98,000 preventable medical errors resulting in deaths in hospitals every year, and compare that to the Sentinel Event statistics from JCAHO, which show that on average only 300 Sentinel Event reports are filed per year, don't you agree that there is a gross example of underreporting of the problem and a failure on the part of the community to address it?
No, not at all. First of all, if you look back at the studies that were done where the 44 to 98,000 figures were drawn from, these were extracted from hospital charts in about 1990, 82 or 83. Now that's 82, 92, that's almost 30 years ago. So there's been a substantial change in hospital practices and events since then. When that extraction was done, they were extrapolated from a few charts and assumed that this was what happened around the country, and the medical errors and negligence were equated, and that is not necessarily so at all. There are things that do happen that are not negligence. So saying that the medical liability system is going to handle, is necessary to prevent all that is wrong. I think that the proper way to do it is what we're doing. We are looking at quality events, and in fact, if the reporting is low, maybe that review should be done again to see if that is the reason. Maybe there's been a change over the past 30 years.
You think there are only 300 preventable medical errors a year happening in hospitals in this country? Is that your testimony?
No, I think that, number one, if you're asking hospitals to report things or doctors report things in the face of a medical liability system where they can be sued for millions of dollars, your incentive to be open is blunted considerably. Change the liability system. Make it possible, like airlines, to report things without being so open to suits that can run you out of practice, and we can have a better system for finding and correcting errors.
Thank you. Mr. Chairman, I would just like to point out that the reporting system I'm referring to at JCAHO is a closed system that is not open to the public.
Thank you. The gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. And that's an excellent point, Dr. Bean, and I'm so glad you made it, because the IOM study was, in fact, published 10 years ago, and it was from data collected 20 and 30 years ago. It's high time, Mr. Chairman. We asked the Institute of Medicine to update that study. The Sentinel reporting techniques have been around for 10 years. maybe we should look again and see whether we've made any progress. I suspect we have, because even then, the data from 1982 and 83 and the data from 1992 showed significant improvement between that 10-year span, and that was not accounted for in the publication to Air is Human. Since Mr. Shimkus took my questions, Dr. Rowland, let me just ask you, you described a Medicaid program that I just scarcely recognized. In my practice, it wasn't a workhorse, it was more like a Trojan horse. All the people got inside, and then you were in trouble. But let's think about it for just a minute. You were the only one who answered affirmatively to changing what you had now for what would be available in a Medicaid system. I offered an amendment during our S-CHIP debate, and I may well offer it as standalone legislation that would allow members of Congress the option of entering the Medicaid system, so perhaps they could see for themselves firsthand what patients encounter. Would that be a good idea?
Well, first of all, I think, sir, that you come from the state of Texas and that Medicaid programs are different in different states. And so one of the issues that needs to be addressed if one is going to build on a Medicaid foundation is to perhaps make the program more standard.
But we had no other members from Texas on the panel here today, but everyone declined the opportunity for taking an adventure into the Medicaid system. I just offer that for what it's worth. Do you think I'll get many co-sponsors on that legislation from members of Congress?
I actually doubt it.
Yeah, I do too.
But I think that it does point out that the program does need improvements as a building block.
There is no
that it
question the
not
program needs
perfect.
improvement. And I did take Medicaid patients in my obstetrics practice, and the biggest problem I had was finding a specialist to whom to refer a patient when she had a problem that was beyond my scope and capabilities. And that, I think, really speaks to the problem that many primary care doctors have when they open their doors to Medicaid patients. If they get a complicated abscess, if they get a complicated cardiology patient, they literally have no place to send that patient, and as a consequence, they may be practicing well over their heads. And that's a patient safety issue that really should not go unaddressed. Dr. Bean, I want to thank you, too, about your comments about the medical liability system. Texas has, I think, done an excellent job. I can't take any credit for it. I have introduced the Texas legislation in Congress. The bill number is 1468 for anyone keeping score at home. This bill actually scores as a savings by the Congressional Budget Office. It's $3.8 billion over 4 years. It's not a huge savings. We spend trillions of dollars at the drop of a hat now. But still, $3.4 billion to $3.8 billion means something to someone somewhere. And I just offer this, Mr. Chairman, as a gift to help balance the budget wherever it might be helpful. I'll be glad to make my modest little Texas medical liability bill available so that other states can, in fact, enjoy some of the things that have happened in Texas. And Dr. Kitchell, in my remaining time, I couldn't help but notice that your notes were handwritten, so I assume you haven't purchased that, what was it, $21 million medical record system that's available to you?
We are in the process of phasing it in, yes.
I understand why, because even from across the street, I can tell that your partners cannot read your handwriting. Let me just ask you a couple of questions, because you have some great testimony about the PQRI, which I thought was a mistake when our side pushed it at the end of 2006. You say it doesn't actually reward quality, rewards reporting. There was a great article in the Journal of American Medical Association a little less than a year ago, and I unfortunately don't remember the author. It was tongue-in-cheek, say make P4P work for you, and it recommended that we diagnose liberally, that we don't be stingy with your diagnoses. If you make more people in your patient panel class 2 diabetics, your hemoglobin A1Cs are going to look a lot better, and as a consequence, you're going to get a better, your payment is going to improve. You incent the wrong type of behavior when you go down the PQRI road. But I do wonder, and you have the statement that there are methodological problems. Are these fatal flaws, or could these be corrected? And of course, one of the biggest problems with PQRI is we didn't pay a darn thing for anyone to gather the data. It was more expensive to try to participate than any bonus that you would get at the out end on PQRI. But are the problems inherent in PQRI, are they so fatal that the program cannot be salvaged and we just need to move to a different scheme?
Let me just preface this slightly. The American Medical Association Physician Consortium for Performance Improvement is developing measures of quality. So we can not only measure, we can reward quality. The AMA should take a lot of credit for developing this. They've taken the lead in measuring and rewarding quality. The PQRI program has chosen to use individual measures. The consortium is now working on more team and system measures. That's where I think we need to go. The problem with the individual measures, as a physician, we don't want to be profiled. We don't want to be tiered. We don't want to be rated individually because our patients vary. Sometimes 3 physicians are seeing 1 patient. So who gets the credit, who gets the blame? That is an attribution problem. So these individual measures continue to promote fragmentation of care rather than coordination of care by teams and systems. We need to think about how we deliver care, and we will do better with raising quality, giving patients safety, improving the value of their care if we measure by teams, groups, and systems. So my proposal would be to change the focus of PQRI to get away from reporting. Let's do measures. And we have some composite measures now, and some groups, accountable care organizations, are willing to be accountable for quality and for cost. It's time we allowed those groups of physicians who are willing to be accountable for quality and willing to be accountable for their cost to let them do that.
Are these along the lines of the physician group practice demonstration model that CMS has been doing?
Yes.
And I would
Dr. Burgess, just one more, and then
I would very much favor us considering in the Medicare system, which is a federal program, if a group practices under that accountable model, to allow that group for their Medicare patients coverage under the Federal Tort Claims Act. And I think we could go a long way towards pushing what is, I think, a very effective policy and getting doctors to buy in. I'll yield back the balance of my time.
Could I just
You can answer.
one last comment, and just so you understand, the Physician Group Practice Demonstration Project also included independent physicians. They were not a group, a formal group. They were independent practicing physicians, and they got together in groups.
Thank you. Gentleman from New York, Mr. Weiner.
Thank you, Mr. Chairman. Some of my colleagues on the other side have been engaged in a furious process of erecting straw men and then burning them down. So let me just clarify a couple of things with your help. First of all, my understanding is the proposal by some is Medicare for all, the idea being that it is a model that people are somewhat comfortable with. It is, in some interpretations, this problem is with this debate is that some people have gotten stirred up about the idea of socialized medicine, forgetting that, in fact, what the social compact is in Medicare has been, with the exception of problems with cost reduction and things that need to be fixed, has been a success that people appreciate. The other false choice that has been offered to us is the idea that not whether members of Congress should be offered Medicaid, but whether Medicaid citizens should be offered what members of Congress have. That's the choice that we confront. What we're trying to do is trying to take programs that are obviously deficient and replace them with models that work better. So perhaps my colleague from Texas should offer legislation offering anyone on Medicaid the same plan that members of Congress have. That would truly be a constructive step forward. It is the premise of our entire discussion that the Medicaid system doesn't work very well and it doesn't treat people as well as it should, or treat physicians the way it should, or reimburse states the way it should. That's a given. And to set the straw man up that, oh, well, we have to have Medicaid for everyone, wouldn't that be a terrible thing? Yeah, it probably would not be anyone's desired outcome, and I don't think any of the collected wisdom of the panelists would suggest that that's the seminal question, despite the somewhat overly dramatic yes, no, get your answer ready kind of inquisition. Let me just now ask a question, if I could. You know, it strikes me that Medicaid is a pretty good deal for hospitals and physicians when compared to no insurance. We actually have an experience in New York City that when as a Medicaid patient coming in the door, a lot of the hospitals in New York are gleeful. At least they have someone with some kind of coverage, some kind of predictable repayment, some kind of a process that they know that they're going to get compensated. So yes, Medicaid looks pretty problematic to a lot of physicians, except when compared to what a lot of people have, which is no coverage at all. But I want to ask a question about the impetus to get more physicians to go into primary care. It seems to me
that the market is not functioning efficiently, that while there's a demand for more of those, while there are more hospitals that are looking and more of our system seems to want it, it doesn't seem like the incentives are getting built in properly. As we figure out how to construct the incentives differently in the context of a national health care plan, should we be saying we'll pay you more? Should we be saying we'll pay more of your medical education if you go into primary care? Should we say we're going to penalize you if you decide to be a dermatologist? I mean, what would be the model if we're going to start from scratch, which to some degree we are? What would be the model that would be, and maybe it's Dr. Mullen, you were the one who I heard speak most articulately about it. What do you think that we should be doing to structure it so that primary care being a primary care physician seems like a better deal?
I think the important thing to note is, unfortunately, there's not a single prescription, a single diagnosis and single prescription here, and it is along this continuum. I think there are things that need to be done in the pipeline. There are things that need to be done in practice. And as you rightly observe, the market is not working. The market's not calibrated in practice to support people very well in primary care. And that's a financial matter in terms of reimbursement. It's also a structure model in terms of the hamster on the maze or hamster on the runner type environment that's been created by the need to churn out as many patients as possible simply to pay the rent. So that the restructuring of primary care with incentives from federal payers as well as others will be hugely important to creating a primary care environment which is attractive to make the market better. But if you don't have the pipeline geared to do that, you'll have ill-prepared people coming, and therefore the investments, Title VII, what do we do about the medical school environment, the culture, to make it more friendly to primary care, community medicine, ambulatory care, and the like. And with graduate medical education, how do we get more people training in those areas with very heavy federal investment in that area?
Can I squeeze in one more question? Is there a whole different tier of healthcare that we maybe need to create on the preventative side, on the diagnostic side, on the nutritional care side, on the testing side? I mean, should we not think about maybe having kind of clinics or mobile things or something that go out and find people before they would go in, who might be disinclined to go into a doctor's office or a hospital? You know, we have a whole collection of senior centers, for example, in New York City that seem like a perfect place to kind of capture people at, you know, in a non-medical, I don't know exactly what I'm describing. I guess it's something before even primary care, you know, to kind of be a gateway thing that would, you know, we seem to all worship at the altar of getting people early, doing more diagnostic, nutrition, all these different things. Should we maybe just think about and I know it's tough asking, you know, a panel of doctors this, but should we be thinking about maybe an extra medical type of structure that grabs people in a way that maybe gets them to do the things that might keep them out of even primary care? I don't know who's best equipped to answer that.
Well, I'll make a couple of points, and I'm sure my colleagues will as well. One of the things that we know about improving the health of people is that if you can take interventions to where they live and work and learn, you can do a much better job of improving their overall health. We've learned this through school-based health clinics. We know it through community-based investments in prevention, some of which I've referenced before, investments in increasing people's physical activity, reducing obesity, and so on. So I would agree with you that there is an investment that needs to be made in going to where people actually spend the bulk of their time, which is not in a doctor's office or in a healthcare setting. The other point I'd like to just make is that we've talked a lot about reimbursement and adjusting that. We haven't really talked about the ways in which medical practice has changed and needing to keep up a reimbursement system that mirrors that. Patients want to get care, not visits. They want to get phone calls, emails, and other ways that will allow them to manage their own care outside of the doctor's office. We don't really have a reimbursement system that encourages and incents that.
Thank you. Thank you, Mr. Chairman.
Gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, I thank you. I just want to say before I get into the questions that this straw man scenario that my friend from New York says we Republicans have adopted has been taken to perfection by the Democratic majority, including President Obama, and I think it's probably time for both sides to stop doing that as we work in a bipartisan fashion to try to solve this health care reform issue. It's hugely important, and I think we can do it. I sincerely believe that we can do it. With that, let me turn to Dr. Bean, actually. Dr. Bean, in your testimony, you noted that in his health care reform white paper, Senator Baucus acknowledged that the current legal environment leads to the practice of defensive medicine. That was his quote. I'd like for you to elaborate on what constitutes defensive medicine and discuss the cost associated with this practice. If you remember during the debate between former President Bush and candidate Senator John Kerry, that was in one of the debates that was brought up, and Senator Kerry said, well, you know, the actual premium cost of malpractice insurance is, although high for the individual doctor, not a significant number. But that's not the real cost, and I wish you would explain to my fellow colleagues on the committee and those in the room what the real costs are in regard to that.
Mark McClellan did a study back in the early, in the 90s, I think it was. The Health and Human Services used that as a basis of a 2003 study and found that the excessive tests prescribed to be certain and protect yourself from liability would cost at that time somewhere between about $45 to $129 billion. Now that updated
per year.
Per year in the healthcare system. That updated to today would be about $170 billion. And the study is debated, but I think it's difficult truly to tell what's in the back of a doctor's mind. There's the diagnostic thing, but there is the fear that's lingering in the back that if you don't cover everything, you are subject to unmerciful liability, unprotected liability. If this were taken care of, I think there'd be a substantial reduction. The other issue about the premium, it's quoted to be 0.5% of medical costs. Of course it's trivial because it's just a small proportion of the doctors of the population sustaining it. It's that bigger cost, if it's a cost issue, that can be saved.
Dr. Bean, thank you, and I'm going to turn now to Dr. Harris because I actually, back in 2005, when I introduced liability reform, tort reform here in the House, I got a letter from the American College of Physicians, and it said, of course, supporting my position on medical liability reform legislation. The American College of Physicians stated that there is, quote, a strong evidence that the healthcare liability crisis resulted in many patients not receiving or delaying much-needed medical care. Dr. Harris, could you please explain to us how the medical liability crisis has negatively impacted access to needed medical care for millions of Americans?
Well, I think that gets to the point that Dr. Bean was making, and whether there is an element of apprehension about doing things by virtue of the threat of malpractice. I mean, it's our belief that liability reform should be part of this large effort to reform the healthcare system in this country. And as you know, we favor putting a cap on non-economic damages. But we also think that in the middle of all this, there needs to be some thought and look at the potential for other options. As you're all aware, the testing of expert courts is one that has been considered. But before making such a momentous step, we would applaud looking broadly to see what are the other options.
Thank you, Dr. Harris. And in my remaining time, and Mr. Chairman, remember I did waive my opening statement. Dr. Rowland, in your testimony, you talked about the Medicaid program and that you recommended maybe Medicaid as a platform for extending coverage to the 45 million or so uninsured and maybe not quite that many who are underinsured. When I practiced, I can tell you that there is a bias against Medicaid recipients. Of course, some doctors won't even accept Medicaid because of the low payment. But even those that do, I think that there probably is a stigma. And certainly if we use the best Medicaid program in the country, of course all 50 are different, but if you took the best as the model to offer to those who are uninsured, how do you get beyond that stigma? And if maybe in the brief time, I guess I have at least another minute for you to respond to that question.
Thank you. Well, we have seen in the implementation of the CHIP program as a companion to Medicaid that many states restructured, renamed their Medicaid program, and tried to eliminate some of the stigma attached with it being a heritage program from the welfare days, and have found that in Connecticut, for example, the Husky program was very popularly received and people didn't distinguish it. When we do surveys of the individuals who have uninsured children and ask them about access to public programs, they say they would enroll if they were eligible. They aren't always aware that they're eligible and perceive these programs to be a good program. I think the other point, though, that one has to make is that when we look at all the survey research over the years, Medicaid and private insurance do relatively the same in terms of access to care and access to care measures for the populations they serve, always far better, obviously, than being uninsured. So while we have a provider participation issue, and that could be corrected, obviously, by improving the way in which providers are paid, and we have a primary care delivery system now that's being used in many states to promote better care, it's important to really look at the overall structure and eliminate some of these state-by-state variations so that it's a better-based program for those low-income individuals for whom private insurance with high deductibles and large amounts of cost sharing may not be adequate, but especially for the population that Medicaid now serves, those with severe disabilities and chronic illness, where the scope of benefits from Medicaid is equally important to the fact that it has low levels of cost sharing. So I think you really need to look at the population being served. And finally, I'd say you also need to recognize that Medicaid is far more than a health insurance program, and that the majority of its dollars are spent on long-term care and on assistance to the elderly and people with disabilities that go well beyond what we're talking about in terms of the federal health insurance benefit plan or any other private health insurance plan.
Dr. Rowland, thank you. Mr. Chairman, thank you for your indulgence.
Thank you. Ms. Capps?
First of all, let me thank the panel for your persistence and endurance, I guess, with this long morning. And I was called many other places, but I couldn't miss coming back to address your statement, Dr. Lovizo-Maury. Thank you for highlighting the role of nurses and our nursing shortage. It's not the only topic on the table, but it's often not on the table. So I want to thank you for being here and to present that large element in healthcare. In your written testimony, you mentioned the need to increase the number of nurses with baccalaureate degrees to create larger pools of nurses who would qualify, among other things, for careers in teaching. What efforts do we need to do? I'd like to really zero in on this. And then one other topic, school-based health clinics, that I know you're very good at as well, to bring to our attention and get on the record here. What efforts need to occur at the federal level to increase the proportion of nurses with this level of education?
One of the key issues is funding for scholarships and other financial aid programs for nurses at the baccalaureate level and for nurses who are transitioning from associate to baccalaureate. We know that these programs over the last 20 years have decreased, and in the past have been a major source of financial support for nurses, and I would encourage every effort to be made to enhance those.
Thank you. And it's so clear that given the cost of living increases, we have less money from federal dollars in nursing education today than we did in the 1970s. And with our shortage, this is something I hope we can do our part in remedying. Of course, recruitment and financial aid is one piece of it. Retention is another. You mentioned, I would love to have you explain a little bit more for all of us, the need to retain newly licensed nurses at the bedside, and particularly the work of the Robert Wood Johnson Foundation in the area that you're calling Transforming Care at the Bedside Project. Briefly describe this, because I still want to get to school-based health clinics, so that we can understand that this is a very important example, and there are other examples as well as to how we can keep nurses engaged in the delivery of health care.
One of the things we recognize is that the pipeline for nurses entering the field is being eroded by the number of nurses that are leaving the field. And these are often among the most experienced clinicians, and they have demonstrated, particularly when they are trained at the baccalaureate or above level, that it decreases medical errors, poor outcomes, and the like. So efforts that will enhance the retention of experienced nurses will directly impact the shortage. The program that you mentioned, Transforming Care at the Bedside, really focuses on trying to develop a cadre of nurses who understand the needs at the bedside and can make changes at the nursing level, but then also disseminate those changes throughout the hospital and to other hospitals that empower nurses to do the best for patients, improve the patient-centeredness, and in the process improve the quality of care. So it really speaks to the issues that nurses often give for leaving the profession or leaving a particular institution that are non-financial. That is, not being able to deliver the quality of care that they feel they were trained to deliver. That's really the core issue that Transforming Care at the Bedside addresses.
It's very important, thank you, that we have this ingredient really strong front and center in our efforts to reform healthcare delivery. One other, finally, if there are a few more seconds for us to get this out to, you mentioned the work of the Robert Wood Johnson Foundation in addressing healthcare needs of our nation's children by investing in school-based centers across the country. I've long felt this. It's not just a bias because I've been a school nurse for so many years. Families trust their neighborhood schools. They'll come there. Not just the school children, but the whole family. That's a good place to deliver care. And we should be thinking about this as a cost-effective means, and I'd like to have you address it, because one of the problems is, and I know this very personally, is the shortage of school nurses and others. Nurse practitioners can deliver great care within the school setting, but that's exactly where we're short supply.
Your points are very well taken. There are 1,500 school-based clinics around the country, and they've demonstrated that by providing care in the local environment, the school is a local environment, it's a trusted area that is close to where people need to get care. You can improve mental health services, you can improve primary care services, and other services that the children and, as you mentioned, their families would not otherwise receive. So these are cost-effective ways of delivering care in the community that addresses, I think, some of the issues that Dr. Smedley was mentioning. People need to be able to get care close to where they live.
Thank you, and I only wish I had time to ask some of the others on the panel for your thoughts, because it seemed like I picked the one person who talked about nurses, but I think there might be other agreements among the panel members that these are areas that we should rightly pursue. Thank you very much.
Thank you. The gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. Thanks to the panel, and Congresswoman Capps, you needn't have worried that the topic won't be continued, because I'm going to ask you the same questions particularly about school-based health clinic. It's great that we have 1,500 school-based clinics across the country, but that's a complete drop in the bucket in terms of what we could use them for. And Representative Wiener introduced this concept of sort of creating a different kind of infrastructure for delivering certain kinds of care. I'm very interested in the school-based health clinic falls right within this, in the concept of place-based health care, and I think you addressed this. But let's go where people are. I mean, we can walk down the hall here. I was mentioning this the other day, and there's a clinic, there's a nursing station suite that we can stop into. And it makes perfect sense to have those resources on site where you can capture certain populations. It's so obvious to me, and clearly other members of the committee as well, and members here in Congress, that our schools represent a huge, huge opportunity to do this. I practiced healthcare law for 18 years, but for 8 of those years I was part-time as a healthcare attorney and part-time working 20 hours for the state superintendent of schools. So I was in schools, and of course what I kept seeing was the impediments to education that were represented by the health status of so many of the students and the need they had to get these services. So I'd like any others who would like to join this conversation to talk about this concept of place-based health care. And we can also view it, I'd like you to speak to, in terms of addressing the workforce issues, internships, residencies, and other things that are associated with those structures. And I'd add as well the concept of medical home, which is typically talked about when you're addressing an individual's care. But I think we should be thinking in terms of the medical home for certain communities. So in other words, the medical home for a school is that clinic. The medical home for a naturally occurring retirement community where people are aging in place, you know, at significant levels, would be a clinic. In the school, it could be a clinic that's being staffed by not just nurses, but pediatricians, so you can get to a workforce issue there. In a clinic where people are aging in place, it's a way to expand the geriatrician workforce, et cetera, so you're getting the primary care thing. So speak to place-based health care as really potentially being a revolution in the way we address a lot of these needs and the public health needs. Anybody who wants to jump into that? Yeah.
Congressman, I would just echo your thoughts. A focus on place and on communities can help us to really think more creatively about how to prevent illness in the first place and, as a result, lower healthcare costs. The examples that Representative Wiener gave of beginning to emphasize prevention are critically important. One of the things that we haven't talked about is good community-based primary prevention. A recent report by the Prevention Institute showed that if we invest just $10 per person per year for 5 years, we can save $16 billion in healthcare costs by helping people to avoid illness in the first place.
Anyone else? Yes.
The American College of Physicians, I don't believe, has policy per se about community-based clinics. However, obviously, the notion of primary care physicians in schools, pediatricians, and then the family practitioners and internists in settings, in adult settings, we have said that the patient-centered medical home is not the only solution, that we may need to redefine, and the ultimate product will be quite different, and perhaps along the lines that you're suggesting. The last point, which I believe is relevant to this, is what was alluded to, the role of nurses or nurse practitioners in this outreach program. The American College of Physicians met with much of the leadership of the nurse practitioner community last July to talk about how we could work collaboratively to try and expand in this team-based concept. And Mr. Sarbanes, as you may be aware, we just published a paper in which we felt that this Medicare demonstration project with the notion that homes may in certain areas be headed by a nurse practitioner, not necessarily a physician, obviously within the scope of practice of nurse practitioners. But it does get to the idea that the end product of this discussion will probably be a very varied set of options and not one simple solution to our healthcare needs.
Thank you all. The other day I was thinking about, well, which level of schools is it most important to have these health centers in? So then so elementary, you think about elementary, and it's obvious why you should have that kind of resource there. Then you think about middle school, and it's absolutely obvious why you would need it there. And then you think about high school, and it's beyond obvious why you would need it there. So 1,500 is, like I said, it's a starting point. And we also have to make sure that the financing mechanism for these centers is one that is not subject to the typical way education gets funding, because then they'll just sort of come and go depending on the situation that the schools face. So anyway, we'll continue to pursue this topic. Thank you for your testimony.
Gentlewoman from Florida, Ms. Castor.
Thank you very much. Just picking up on what Mr. Sarbanes and Ms. Capps were saying, I want to ask a quick SCHIP question. Years ago, the precursor to SCHIP started in Florida under Governor Lawton Chiles. It was conceived early on as making it as easy as possible for parents to enroll their children in health insurance when they started school, when they started the school year. Unfortunately, in the intervening years, the political leadership in Florida changed, and folks there saw enrolling kids as a cost rather than an investment. We've lost a lot of ground, and we lost that link between the start of school and signing up children for health insurance, making sure they got their checkups and immunizations. Are states across the country, do other states still have that link?
Many states really use, and the Johnson Foundation has helped to promote through its Covering Kids initiative the first day of school as a real day to try and alert parents to the fact that their children may be eligible. There's more that could be done to use the schools as a enrollment facility and to simplify the enrollment, but it has been one of the main outreach focuses for many of the states in their efforts to enroll more children, and I think it's a very critical place in the community for people to come. One of the things I was going to note is in New Orleans, where Katrina destroyed so much of the healthcare system, they're rebuilding it community by community and using the schools as really the focus for where they put their clinics and for where they organize their services, which will also help contribute to more people being able to gain access and participate.
Way for people to find out about SCHIP, but there are other areas, other locations where people naturally gather that can be used as to increase enrollment, and tying enrollment to other kinds of services like school lunch programs and the like makes it easier for parents to make that linkage and not have to go to extraordinary ends to actually get enrolled.
Yes, I was
And
surprised.
stay enrolled.
I was surprised to learn I had my local housing authority director paying a visit on a totally separate topic. He said back a few decades ago, the housing authorities used to have very expansive clinics in some urban areas. That makes a lot of sense. In my urban county in Tampa, Florida, it's Hillsborough County. It's about 1.2 million people. About 15 years ago, there was a fork in the road. They were paying for very expensive care in our ERs and a number of our emergency rooms out of property taxes. They said there must be a better way, and said instead let's shift from property taxes to a different revenue source. We take a half-cent sales tax and have developed this collaborative effort with the hospitals and doctors and community health centers, and have established a number of neighborhood clinics and that are really out in the neighborhoods. Some community health centers and then other hospitals have their own clinics where their doctors have to take turns, and teaching hospital, a lot of the residents from the University of South Florida are there. And it's a model program, and I know there are some other models in San Antonio and I believe in Oakland. How do we, as part of this healthcare reform effort, how do we incentivize these communities? What's going to be the role? I don't want healthcare reform to happen in a vacuum. There are some good things going on out in the world.
I am familiar with some of those programs because our foundation helped fund many of them. And I think before I address the issue of incentives, let me just speak to one of the major disincentives that was operational in many of those programs. They were, as you say, locally generated, addressed the needs of the local population, but many of them found that they could not sustain themselves because the base was not large enough to cover the costs of people's insurance and health needs over a longer period of time. And that's really one of the things that has made us favor federal programs that can ensure that these locally generated programs actually have the funding base to provide care, not just in prosperous times, but also in times when the community is not as prosperous. In terms of the incentives, I think one of the things we saw in putting out applications for these kinds of programs is that communities do know the kinds of services that they need. and they will come together and organize to provide those kinds of services. So I think that providing that kind of a mechanism is going to be a valuable incentive.
And it saves money. The administrative costs are very low. There aren't any HMOs involved. It's administered by the county, and the hospitals love it because they're getting compensated for medical services that otherwise would go uncompensated in charity care. But if you have some other ideas and examples of communities that have programs like that that are working, I'd appreciate it. Thank you, Mr. Chairman.
Thank you. I think that concludes our questions, but I really want to thank you all for being here today. I know it was a large panel, it covered a lot of things, but it was very worthwhile in our efforts to put together reform legislation. The way it works, you may get additional questions in writing, and then we would ask you to respond in writing, I think, within the next 10 days or so. But again, thank you for your input. As you can see, there's really a lot to cover here, but we're determined to move forward with reform this year. So without objection, the meeting of the subcommittee is adjourned.